Welcome to day one for ALCO Tobacco and Controlled Dangerous Substance Interim Studies. We will start with Representative Rowe, and you are free to take over.
Thank you, Mr. Chairman. We've had a little bit of a change. We initially had another speaker that was scheduled for 9 o'clock, and she's had a death in the family and could not be here. We do have her presentation that we can print and make available for those of you that would be interested. And I do want to make one other comment. Representative McDougall has an interim study tomorrow at 9 o'clock that you all might be interested, that kind of goes along with my interim study. And so I was going to invite any of you that weren't aware of that to be here tomorrow for his study, because he's going to have some really good information in his as well. So we'll get started. First up, we have Barrett Brown, who is the Deputy Director of the Oklahoma Medical Marijuana Authority. And if the speakers, when you come to the microphone, you can sit if you like, you can stand if you like, whichever you prefer. If you will just introduce yourself and your job title, this is being live streamed, and that way those that are listening and watching from outside the room here can know exactly who's talking. Okay, I'll turn it over to you, Barrett.
Thank you, Representative. Thank you, Mr. Chair. My name is Barrett Brown. I'm the Deputy Director of the Oklahoma Medical Marijuana Authority and also the Legislative Liaison. I will be quite brief in my comments, but as it relates to OMMA, the complaints that we get regarding minor usage of marijuana basically fall into three separate buckets, and so I'll kind of address those individually. The first is using products that they get from their parents that are left out, or grandparents, perhaps from a friend, something like that. The second is accidental overconsumption of products that they are licensed to consume. And then the third is using products that contain some sort of analyte that is not naturally occurring, and I'll get to that in just a bit. So on the first, which is using products that they get from parents that are left out, or grandparents, something like that, we have packaging labeling requirements that we currently enforce. All products must be in child-resistant packaging, and then they must be labeled with a universal label saying that this product contains THC and things like that. Candidly, I'm not sure what more OMMA could do about this. We are working towards providing hopefully a little bit more education or guidance to patients and caregivers, so that they can know just sort of generally the forms of THC that are out there on the market to be consumed. And that dovetails with the second kind of bucket that we get complaints on about minor usage, which is accidental overconsumption. There are a lot of, for those who are not involved in the cannabis industry or who are not educated about the cannabis industry, there are a tremendous amount of products out there for which you can consume for THC. And I think a lot of people are just unaware of the various ranges of potency of a lot of those products. And so we have gotten some complaints about minors using products that they just didn't know what they were or how much THC was in them, which eventually results in poor outcomes sometimes. So something that we're talking about internally and working towards on this specific front is we're trying to get some medical professionals on staff, whether that be contracted or whether that be full-time, to assist us in developing actual guidance that we can give to patients. So at the point of licensure, when a patient receives a license, we'd like to be able to give them just a bunch of information that they may know or they may not know. The various forms of THC, kind of standard dosages of the different forms of THC, so that they can be aware of that. And also, I don't think in the past OMMA has had a great relationship with the medical community, and we'd like to build a bridge there so that we can educate physicians who are recommending THC of things that they may not be aware of. And another conversation that we've had with a lot of different people is the idea of developing an occupational license for a bud tender. which is kind of like a bartender but for marijuana, so that it's somebody at the point of sale dealing with patients who may not know what they're doing, to kind of guide them through that process and lead them to a product that might suit their needs. The third and the final thing that I wanted to talk about is complaints that we've gotten for using products that contain an analyte that's not naturally occurring. I'm sure you've heard about Delta 8 or perhaps Delta 10, which is sort of a regulatory gray area. Pursuant to Senate Bill 1033 last session, the definition of medical marijuana was amended in Oklahoma statutes to specifically exclude Delta 8 and Delta 10 THC. So the authority that OMMA has to specifically regulate these products is unknown, kind of on shaky legal ground, in my opinion. And some efforts that we're doing to kind of get a hold on that is, number one, first and foremost, our QA lab, our quality assurance lab, which is a contracted lab with the state to test samples. We're trying to get them out to test as many samples as we possibly can so that we can pick up on where this D8 and D10 might be coming from, where it might be found, the kinds of products that it might be in. And then legislatively, obviously, we'd like to clean up that definition of medical marijuana so that the onus of the regulation on D10, D8 is, if not OMMA, then somebody else, whether that be OBN or otherwise. And for OMMA, our biggest priority is patient safety. We want the regulatory environment in Oklahoma to be tight so that we can say, as much as possible, every product that is grown, processed, and sold in Oklahoma is a safe product that patients can use with confidence that they know what they're getting. And that I'll give the rest of the time back to the committee, and will be available for questions.
Does anybody have any questions? I do want to interject something that I should have stated from the beginning. The intent, my intent with this study, we had a great discussion with all of those involved before the study, was my concern was the lack of follow-up in the pediatric patient. My intent is not to take away anything that is being done, but my intent was to look at follow-up. Is it like with any other kind of medication? Is the medication doing what we want it to do? And are we doing it in a manner that's safe for the growth and development of the child? And are we identifying any potential adverse effects that aren't being picked up because a lot of these kids are not following up with a primary care provider, just like a kid that takes medication for ADHD, does counseling for ADHD. Providers follow them on a monthly or every other month basis to make sure that the medication is doing what we want it to do. And in a lot of instances, this is not being done. And if nobody has any questions, I'm going to turn it over then. I'm sorry. Go ahead.
Mr. Baird, thank you for coming in today. I appreciate it. Couple things, just more of that I've heard representatives over the past couple months talking about that relate to the subject. You got off on packaging and how packaging is child resistant. I think anyone that's dealt with those packages realize they're extremely child resistant. But right now we have that they are opaque and not clear, so you can't see what's in them. I know there's legislation coming this session to allow for clear packaging. Do you guys have a stance on that?
No, sir. I don't think we do.
Do you think that it would entice more children to dig into that packaging, or?
That's a good question. I mean, as far as packaging is concerned, enforcement has obviously been lacking, and specifically the enforcement of packaging at the point of sale has not been, I would say, a huge priority in the past. I think that's something that as we ramp up our enforcement and inspect every business in the state of Oklahoma at least once by the end of next year, that's something that we can keep in mind. And I think especially as it deals with how desirable a product may appear to minors, to children. I think that's something we need to take on a kind of a case-by-case basis. I don't know if that answers your question or not, but
Well, it's like right now, if there's a brownie in the package, you can't see the brownie. If there's a cookie in the package, you can't see the cookie. Right. And our regulations currently on expiration dates and beyond use dating are not there. So it does make good sense for people to see something before they purchase it. But maybe a packaging that you have to peel away, something that can go back. You know, you open cookies, you can eat some and latch it back. Maybe something like that for a window. Just thoughts I'd like this committee to, and hopefully most of them are at home listening, to understand that there's a reason why we don't want kids looking at brownies in a package, because whether they're hard to get into or not, kids will find a way to get a cookie or a brownie, whether you tell them not to. The other thing you touched on was occupational licenses. Do you think, as most of this building has been trying to go away from occupational licenses, that it might be a tough ask to require more licenses?
sure, yes, I absolutely agree with that. And I mean, personally, it's something that I don't know that I fully thought it through and dismissed it outright when I first heard about it, because when I think of a bartender, I don't necessarily think of providing a lot of guidance in terms of the consumption of alcohol. But I think there's a fundamental difference between alcohol and THC in that this is a pretty new marketplace in Oklahoma, and there's various different products that I think most people are just unaware of. And I think there is a need, as Representative Rowe mentioned, for some sort of follow-up after the recommendation from the physician. And granted, this would not be a trained medical professional, but ideally we could accompany some training with the licensure so that these are people who are at least knowledgeable about the products and can provide some form of secondary guidance after that initial recommendation from the physician.
Okay, thank you. One last thing. When you talked about Delta 8, Delta 10, is that something that needs to be better defined and included as THC so OMA can have control over it and has been excluded? Is that what the reference to that was?
Yes, so currently in the definition of medical marijuana, it specifically excludes Delta 8 and Delta 10 THC. OMMA has authority to regulate medical marijuana and medical marijuana products. So if Delta 8 and Delta 10 is not included in that definition, then we cannot regulate that as a marijuana product. Effective November 1, which is today, the legislature has given us a little bit broader authority as far as testing and controlling products that are dangerous to public health. So we could push on that to say Delta 8, while not a marijuana product or not medical marijuana, is an analyte that is otherwise dangerous to public health, and hopefully control products flowing downstream based on that legal justification. But whether it's regulated by OMMA or whether it is illegal and therefore regulated criminally by OBN, I think doesn't make a whole lot of difference to us, but I do think it is something that needs to be addressed because we are seeing it in the marketplace. It's closer to K2 and Spice from a few years back, whenever that hit. It's a product that is marketed as legal and oftentimes contains varying degrees of potency of not only D8 and D10, but other different analytes that we just don't know what is in it.
And those two drugs are not currently listed on the OBNDD's controlled dangerous substances list that we produce annually?
No, I don't believe so. And they're not on the federal schedule currently either.
Okay. Thank you.
I do have a question. So
Yes.
am I correct in assuming that a lot of the packaging issues that we've had are not from not product that's made and packaged in Oklahoma? I can think of an instance. OBN had a thing on their website here some few months ago and it stemmed from an incident where two or three children had gotten into some medical marijuana product. There was 600 milligrams in the entire bag, and they were packaged to look like chili cheese Fritos, cheddar sour cream Ruffles, and I forget what the other one was. It's my understanding those were black market product that was not. So you guys are, I mean, am I incorrect in assuming that Oklahoma producers are doing this correctly, and a lot of these packaging issues are from black market product? Is that correct?
Largely, yes. I wouldn't say that all Oklahoma producers are doing things correctly, and we are working to figure out which ones are and which ones aren't. But for packaging, like the instance you mentioned, yes, that is a black market product, and that's something that we are worried about, obviously, and even though we don't have the authority to regulate that on the criminal side, that lies with OBN or the federal government if they were interested. We want to ramp up our enforcement efforts to figure out who's doing things the right way, who's importing product, and then work with OBN and local law enforcement to get those places shut down.
Are there any other questions? Okay, if not, are you all switching?
Yes, ma'am.
Okay, so we're going to switch the agenda here just a little bit. I think she's getting kind of tired of sitting listening to all of us ramble on and on. So I was very touched by Mr. Laffey's story. And I want to introduce Michael Laffey, and he's got his daughter here with him, and I will let him tell his story and give us his presentation. So if you'll just also introduce yourself, and we can scoot a microphone down if you don't have one there. If you'll just press the little button, the green light comes on, will show you that it's on. And we will turn it over to you if you'll just give us an introduction to start off with.
Well, thank you. I am Michael Laffey. I'm the Chief Marketing Officer of Vertical Vibes. We are a grow, processor, retail organization completely vertically integrated out of Lawton and Marlow, Oklahoma, with retail locations throughout the state. I'm also the Vice Chairman of the Cannabis Industry Advocates of Oklahoma, and I am not a lifelong cannabis user. I was introduced to cannabis when 788 passed, just like everybody else. But previous to that, I have this little miracle named Maggie right here next to me. There is a video that we can play that kind of tells Maggie's story. Everything happens for a reason. Man, if I hear that one more time. Special children only go to special parents. That's another good one. We're no different from any other family. We love all our kids in the same way.
Shortly after birth, Maggie was diagnosed with a rare genetic brain disorder. A couple years later, another diagnosis.
Even more rare, Kask syndrome.
Then epilepsy.
Then hip dysplasia.
Then type 1 diabetes.
The list just keeps going.
Many thought she didn't have much time here with us. She has had her share of hardships, but she is 10 now.
The truth is, we don't know how much time we have with her.
But we don't control that.
So we focus on today.
Even though she cannot walk,
She cannot talk.
cannot even eat, we know there is one thing she can do. Smile.
So that was Maggie's story from about 3 years ago. Since then, we can add full spinal replacement and a few other surgeries to the list that just keeps going on and on with her. When she was about 4 years old, she started having seizures to the tune of 20 to 30 a day. And we went to the doctor, and we received Topamax and Keppra, just like every other child that has epilepsy had. And you may not see it here, but Maggie has one heck of a personality. Her mom and I get to speak her language. Most people don't get to see it. But when we gave her those drugs, she became a shell of herself. She lost her personality, and essentially she became a zombie. So I was introduced to CBD products many years ago by a friend of mine from Arizona, where we illegally had to drive up to Denver to purchase these products. Started out with broad spectrum CBD, which has 0 THC in it. graduated into full spectrum CBD, and we have experimented with several extremely low doses of THC. Since that time, she's gone 7 years, 6 months, and about 20 days without a single seizure. So the THC medicine that we provide to Maggie, whether lawfully or unlawfully, I believe saved her life. I believe she's 13 years old as of last week, 7 years without a seizure, and we also see that her type 1 diabetes is much more under control since we've been giving her these products. We've gone from 7 or 8 insulin shots a day to 1 or 2. The reason I'm here is I'm not here to advocate that all parents should give their kids THC. I think that parents that have children who are struggling through life, through normal medicine, should have the opportunity to choose. Here's the issue with that. Go on Google and try to find a doctor that says, here's what to do. There really isn't a lot of that out there. There isn't a doctor or a neurologist, in her case, that can go through and say this much THC over this period of time, this many times a day, is going to help ease the burden of seizure activity with Maggie. We just simply couldn't find it. When we go to the doctor now, we tell them what we're doing, and they're like, whatever you're doing, please keep doing it. We just don't know. And so until the PhD and MDs catch up to what the plant can do, it's going to be very difficult to ask them to prescribe specific doses. There's another thing here. Maggie is 13 years old and 32 pounds. A regular 13-year-old is going to be 110 pounds. That metabolism difference is going to be different for every single patient that walks in the door. So asking for a Advil or Topamax type prescription based on someone's age is probably not going to be the way to go. So we've done a lot of experimenting over the years, and I will tell you that Maggie is a very unique person. She has an endocrinologist who's PhD, MD, all of those things, 20 years in the business, works at OU Medical Center, and she cannot figure out in the book how to prescribe her insulin because she's such a different person. So we've had to experiment, take too much, take too little, do all those things, and when she goes into the hospital for overnight stays, I actually have to go into the administrator's office and sign a release form that says the parents will control the insulin, not the doctors. So if it's that way for a traditional medicine, how hard is it going to be for a doctor to actually prescribe a non-traditional medicine in which they have no education about? So that's Maggie's story. She's thriving, she's doing fine, but everything that we have done has been trial and error. And the worst possible thing that we did if we gave her too much THC is she took a nice long nap. There has really been no adverse effects to too much, but we're talking about 0.5 milligram doses in a tincture that is fed through a G-tube. This is not give her a gummy and see what happens. This is not smoke some cannabis or nebulize the cannabis. This is simply tinctures that we are feeding her through her G-tube. Some of the doctors say that many of the effects that we're getting could be coincidental. Well, they could be. But right now, it's what's working, and it's what's helped her live the best 13 years that she can live. And like the video explained, we're not trying to fix her. We're just trying to give her the best opportunity to be happy as we can. And right now, I can't find those answers at a hospital. I find them at a dispensary. Any questions?
Does anyone have any questions for Mr. Lafferty? If not, thank you all very much.
I do apologize because she does speak out of turn when she feels like it.
Do not apologize. We're happy for those happy noises that she's
Right.
making.
I think we'll try to stick it out as long as she's quiet. But if anybody else has any questions, if anybody has somebody that is wondering whether this works for them or it doesn't work for them, I can't answer that. The only thing I can answer is what works for her.
I can tell you that her noises do not bother me. They seem like they're happy noises, and
They are
she's
happy
smiling.
noises.
And I would be hard pressed to find that anybody in here is going to disagree.
She's wondering why she's not at school.
Thank you for coming and sharing your story.
You bet.
We appreciate it.
So next, I'm going to turn it over to Nathan Richter, and he is going to give us a presentation on what he does and what his organization is. And if you can introduce yourself before you start, that would be great.
Yes, ma'am. Can everybody hear me? Is the mic on? Oh, there we go. Chairman Marty, Representative Rowe, members of this committee, and distinguished guests, thank you for the opportunity to speak today. My name is Nathan Richter. I'm the CEO of Nature's Key Edibles. We're an edibles manufacturer in Oklahoma City. I want to start first by saying, as a licensed lawyer in the state for the last 14 years and also a board member of a youth shelter out in El Reno, I want to thank you guys for taking up this topic and for your interest in medical cannabis and how it relates to pediatric patients around the state. I think it's a very important topic when we talk about packaging and we talk about dosing and we talk about monitoring, that children are our best future, and we want to make sure that we give them the best future. And I echo some of the things that Mr. Laffey said. I don't think anybody's in the industry trying to fix people, but we're certainly trying to give people the best quality of life they have while they have it. I want to introduce a little bit of my team and the company. I have the privilege of running. Nature's Key is an edibles manufacturer, like I mentioned. We carry out the vision of serving the patients of Oklahoma by making the healthiest, most consistent medicine available. So cannabis patients can trust that what they're consuming is actual medicine. Our vision is very simple. We want to provide an intelligent roadmap to help cannabis patients effectively, efficiently, and safely find their therapeutic dose and monitor their progress. And how we accomplish that is primarily through education, through our internal manufacturing standards, and through transparency. We also work very closely with a medical cannabis physician out of New York. Her name is Dr. June Chin. Dr. Chin serves in an advisory capacity for Nature's Key. She has been instrumental in helping us with formulations, with the dosing protocol, and has weighed heavily on this presentation from a doctor's perspective. As Mr. Laffey mentioned, you might find it funny how difficult it is to find a doctor that's willing to even talk about cannabis, much less advise and provide consultation. Dr. Chin and her team of physicians consult with pediatric and adult patients all over the world. They've integrated medical cannabis into their clinical practices since 2001. She's also currently working with the state of New York on their launch of their New York's cannabis program, which I'll talk a little bit more in a minute. I want to start today by reminding us of what the cannabis industry has really done for children. Mr. Laffey and Maggie provide a very compelling story, and like Maggie, there's other children in the state that suffer from various medical conditions who have benefited from cannabis, and I want to introduce you to Jaden Clutter. Jaden is now a 16-year-old Nature's Key patient who suffers from Chiari malformation. I'm not a doctor, but I had to look it up. So Chiari malformation is a structural defect or problem in the brain that, in Jaden's particular case, resulted in temporary and frequent paralysis, debilitating seizures, and she underwent multiple surgeries. This short video clip is a clip of Jaden's mother, Leanne, explaining one of the more challenging times that she had with Jaden. And I'm not sure how I can play that.
No, I still remember putting her in the tub to this day and pouring water over her head. And her whole face paralyzed. And she couldn't talk to me, and she only drooled.
Jaden is one of 4 dozen pediatric patients we know who are being treated with medical cannabis around the state for conditions ranging from epilepsy to Tourette's to intractable seizures. All of these patients and their families, similar to Mr. Laffey, face incredible challenges every day. Their courage is inspiring. Their resolve is admirable. But to see them overcome their challenge, overcome their condition, that's not only life-changing for the kids and their families, but it's impactful to each and every one of us. The Clutter's journey through Western medical models and visits, testing, follow-ups, trying to get the medication right, as Mr. Laffey described with Maggie, provided Jaden with some temporary relief. Her her conditions were managed, as they say. But the family was discouraged. They really thought that there was more for Jaden and more for her life. And so Leanne kind of took matters into her own hand, believing that there was better, and was turned on to Nature's Key gummies. We primarily make gummies. Nature's Keys gummies, which is a line of medical products that we designed to help patients, especially kids, titrate or find their dose. By using this particular roadmap, Jaden was really able to find the right dose that worked for her and really experience some incredible results.
Yeah, no,
come along and my parents are working at the dispensary, and this neurologist came and she introduced me to Nature's Keys. And that day when I was introduced, I wasn't feeling my best at all. That's when I started athletics and stuff, and I was just, I wasn't feeling it. And so they gave me this gummy, and I took it, and they gave me like half one, and I took it, and I was just sitting there watching TV, listening to music and stuff. And it was around 5:30, and that's when I start heading to church, and I'm like feeling great. I'm feeling awesome. I just want to get on with this day and everything. And so I'm like, yeah, I'm good. And my mom's like, are you sure? I'm like, yes, I'm good. So she bought a bag of these gummies, and I started taking them every night or when I'm in pain. And honestly, I think that that's when my life changed. Is when I started taking the gummies. Like everything changed, and we started getting into like trying new things and everything. So I started taking CBD gummies in the morning and 25 ones at night. And that's when I had to go to the hospital to see how much my dosage for my medicine for my epilepsy. And they're like, we don't see any activity or whatever you're doing, keep doing it. And my mom was like, we have her on these 25 ones. They're like, well, keep doing it. I'm coming off my seizure meds, and I'm seizure meds free since July 1st.
So there's a couple of things I want to point out about Jaden's testimonial. First, it was a neurologist that turned her on to an edible product containing THC. Second, she took that in a normal course of her day. In fact, she mentions in the clip that she's on her way to church. She took the gummy and felt really amazing relief from it. After her and her parents adjusted their regimen of CBD and THC, Jaden returned to her doctor at some point in time in the future and realized after they had run their tests and followed up with her that the doctor found no epileptic activity in her head. Over time, her pharmaceutical doses were reduced, and as she mentioned, she's been off of her seizure medication since July, completely off. So what do we know about pediatric dosing and monitoring with medical cannabis? The answer is we really don't know much at all. What we're doing is we're learning how the plant works and how it works within patients. But what we do know, and I think it's the most important thing, is that responsible, educated parents who treat cannabis like it's a medicine, who adopt safe practices like locking up their medicine and keeping it away from children, and who can trust the products that their children are consuming to be consistent and to be medical grade. Those parents, the responsible, educated parents, they're changing lives every day with this plant. There's three things I feel like when we look at Jaden's story that we can focus on today when we talk about pediatric dosing and monitoring. We can talk about defining a true medical market, what that means within the plant. We could talk about education, which has already been mentioned a couple of times, and then the consistency of the products and the manufacturing standards available. So from a medical standpoint, what is medical cannabis? The way in which we think about healthcare and the models and the research and the data, those things have largely been unavailable to cannabis. Cannabis was widely used as a patient medication during the 19th and 20th centuries. It's been described in the United States Pharmacopoeia as early as 1850, and the roots of cannabis as a medicine or have been documented dating back more than 5,000 years. However, in the 1970s, when the federal government passed the Controlled Substances Act, they included cannabis as a Schedule I drug, and the studies of cannabis's efficacy as a medicine were largely quashed. Currently, we've seen a shift in the country, as this slide shows. The shift in the country would show that, roughly 8 states now, I think, are legal in some capacity. You've got states that have a medical program only, like Oklahoma. You've got states that have both a medical and a recreational program. And so there's a lot of confusion across the country when it comes to medical programs. To add to the confusion and to the problem, you've got the federal government, who's largely just taken a step back and said, we're not going to deal with it right now, and yet left it as a Schedule I. So you've got this overarching illegality. I think the glass half full approach to this view, if you will, of cannabis landscape across the country is that the federal government's done what some would argue is our system's built on, and that's to allow the states to experiment. Allowing states to develop their own programs and allowing states to develop their own markets is largely what they've done, and it's been very good, especially in Oklahoma. We've done a great job, or you all have done a wonderful job rolling out the program. It's one of the more robust programs in the market. There's access is there for just about anybody who would like to consume cannabis as a medicine. But there's always a little bit more work that we can do. As we talk about the medical side of cannabis and the illegality at the federal level, you can imagine how challenging it is for any healthcare provider to want to step in and put their toe in the water. They have all kinds of questions that really are difficult to answer, such as how do we prescribe it? What's a recommended dose? What's the medicine safety profile? What dose is right for what condition? How do we know the information we can trust? What are the drug-dependent interactions with cannabis? How do we administer it? These are questions that doctors ask me all the time when I'm talking to them about how they're incorporating cannabis as a treatment for their patients. In addition to that, there's legal concerns. What's their liability for both their clinic or their hospital or themselves? So when we look at pediatric patients, how they're being dosed and how they're being monitored, and how they're taking cannabis as a medication, I think we have to remember that if we're looking at it through the lens of a traditional Western medical model, cannabis is at a disadvantage from the start. Those FDA trials, those clinical trials, the FDA approvals, and all the studies that go into approving a medication to go to market do not and have not existed for cannabis for years. Instead, as Mr. Laffey explained with Maggie, it was through trial and error and titration methods that cannabis patients have managed to find what works for them. Further, it was mentioned briefly, to complicate things, the cannabis industry has evolved so quickly. There's thousands of SKUs on the market. There's thousands of brands and labels and all sorts of different products available, and it's caused a lot of confusion with medical patients as to what's really a medical product and what may not be a medical product. And then, of course, today we've heard a couple of statements about accidental ingestions. We've seen across the country, and it's not really a surprise here in Oklahoma, that with the sort of new access, if you will, to cannabis, there's been a rise in accidental ingestions amongst children. A study I found, which concerned me as an edibles manufacturer, was a 2019 study of 10,000 ER visits that found that when children accidentally ingest cannabis, edibles are 33% more likely the culprit than a smokable, for example. We've done a good job in Oklahoma with child-resistant packaging. We've done a good job with avoiding, by and large, products that are marketed and labeled to children. But again, there's a lot of confusion out there, and there's a lot of different products on the market. In my research, I found, and as you would expect, children under the age of 6 are incredibly susceptible to accidental ingestion. For those that have children or those that have been around young children, when they walk around or when they find their freedom of movement, the first thing they do is explore with their hands. And the second thing they do is whatever they find, they stick it in their mouth. And that is not going to be different for cannabis as it is for any other medicine. When you drill down into the 2019 study by the National Poison Center, you find out that the vast majority, or the main culprit, I should say, of poisonous exposures is actually cosmetic and personal care products. Cleaning substances are a close second, and then you have your analgesics, your painkillers, your opiates, your narcotics, and all the things that we have way too much of an intimate relationship with in Oklahoma. Further, I thought this slide to be profound in the sense that this is a 1980s poster, I believe, again from the Poison Control Center, that shows medicine compared to candy. And while cannabis is not up there, you can see how similar candies are to all types of medicines that are readily available over the counter today. Red Hots, looking like iron supplements, multivitamins looking like Good and Plenty's, Tylenol looking like Tic Tacs. Medical cannabis is no different. The truth is the problem doesn't just apply to cannabis. It applies to NyQuil, opiates, antidepressants. There are many over-the-counter drugs that look just like medication that we have to be cognizant of so that we keep our kids away from them. In fact, the CDC reports about 60,000 kids end up in the ER every year because they've got into medicine they weren't supposed to. That's 4 busloads of kids a day that get into medication, not just cannabis, but other medication. What's important to remember is that if we treat cannabis like a medicine, then we lock it up. We treat it like any other medicine. We keep it away from kids. If we define a true medical market and we recall that cannabis is a medicine, then parents, adults, and really any person around a child that's consuming cannabis, they must practice safe storage. They've got to be responsible and educated about what cannabis may do. We don't legislate the storage of household cleaning supplies or cosmetic products because of accidental ingestions, nor should we with cannabis. At some point in time, the onus is really on the adults in the room to make sure that kids are not around cannabis in a way that they could grab it and put it in their mouth. From an education standpoint, so we talk about Jaden's success and her journey. Her success was largely due to her education. And at Nature's Key, we believe so strongly in education, we're here to educate as many people as we can, including bud tenders. The OMMA mentioned that bud tenders serve kind of like bartenders in dispensaries. And they are the frontline engagement with the patient. When the patient walks into a dispensary, the first person they see is a bud tender. Cannabis education is important for all players in the wellness game, but no more, I shouldn't say no more, I should say it's important for everybody in the game, but more importantly, it's for the person that's actually talking to a patient about what product they can consume. For patients to understand, for example, in edibles, we want bud tenders to be able to explain that a range of dosages from 1 to 2.5 milligrams might cause the patient to feel a mild sedation or a burst of energy or, mild relief from pain and stress and anxiety and those types of things. We also want that particular bud tender to know that if it's a 50 to 100 milligram product, the effects are vastly different. We go through our Bud Tender University and we explain how THC is metabolized in the body, why that's important, and how it reacts differently with people. All of these things are critically important for a bud tender when they're interfacing with a patient. At the end of our presentation, we give a little pop quiz, and we provide the bud tender with what could be a potential scenario that they would face. And we ask that bud tender, based on the products and based on the effects and based on the dosages that we've educated them upon, what they might recommend to, in this case, grandma. In addition to education, we at Nature's Key have put a patient-forward focus on a medical cannabis program we've developed. This particular program ties together the patient, the medication, the education with clinically focused dispensaries, all of which can use an application we're developing, which is a technological platform that allows the patient to track their cannabis usage. It also allows them to track their vitals from their smartwatch or their smart device. and allows them to communicate through a HIPAA-compliant server with their dispensary or their provider. The app assigns a protocol, if you will, to a patient following a series of questions and answers like a survey. And then the application will, based on the doctor or the dispensary's recommend a dose of a product or a particular product for a condition. And then that, again, allows the patient to consume, track, and provide feedback, something that really doesn't exist today. When we talk about education and we talk about treating cannabis as a medicine, for Jaden and her success, we have to talk about consistency as well. The last element of Jaden's success was the fact that she was consuming a consistent medical grade cannabis product. It's important to remember that with as quickly as the cannabis industry has evolved, there are a lot of products on the market that may say 25 milligrams on the bag, and they may be 30, or they may be 35, or they may be 15. The variances in dosing are pretty incredible, and this is across the board, not just in Oklahoma. Consistent medicine is absolutely the key to a patient's success. If they can't trust what they're putting in their body, how are they to know where their journey will take them? At Nature's Key, we are transparent with our lab testing, and we have internal standards that keep our variances within the 10% variance. That is also the same variance from the FDA's perspective on pharmaceuticals. Internally, we are at across all products plus or minus 5%, and our goal is to be at plus or minus 3% by the end of 2022. But the consistency of the medication is absolutely critical to ensure that that cannabis patient knows what they're consuming and can trust it. In addition, we're hoping that with the defined medical market, bud tender, and public education, certainly consistent medication and a cannabis program that's designed to fill the gaps between the patient and the provider, that Nature's Key, its program, can serve as a model to scale for larger multi-site programs across the state. Right now, as I mentioned, Dr. Chen and her team are working with New York. They're working alongside their medical clinics, and they're treating pediatric and adult patients alongside cannabis regulators in New York to ensure that the patients within that program are safe. They've developed legally compliant medical marijuana programs for healthcare systems. They are utilizing structured modules, clinical training, billing protocols, implementation strategies, evaluations, and patient safety protocols to scale their entire system. This evidence-based approach not only allows for patient safety, but also allows for the gathering of critical data from both the patient, the practice, and the population levels to assess and achieve that clinical impact that we're looking for. Pilot programs provide a model for what a true Oklahoma medical program could be, and they provide the appropriate checks and balances, collaboration, and consistency that's deserved by all medical cannabis patients, young and old alike. So a few points from our observations with Jaden and with other patients. Medical market, do we educate? And then what kind of product standards do we want in Oklahoma to protect our children and to protect our patients? And with that, I'll take any questions.
I do have a question. In one of our meetings, and I can't remember if it was when you all were in my office or when we had our big round table, I don't remember if it was you or someone else, we were talking about the different ways that the cannabis was infused into was that you that told us that? So I thought that was a very interesting tidbit of information, but I can't remember it exactly. Could you tell us about that?
Yes, ma'am. So in the industry, there are many different ways to manufacture or make a cannabis edible. One way is to infuse. Nature's Key blends a mixture in the gummy, infuses it with the medicine itself, and then pours the mixture into forms and doses the gummy through infusion. There's another way you can bathe a gummy. In other words, I could go to any real C-store and find a gummy product and wash it, if you will, or bathe it in a distillate to coat the medicine on the product itself, or you can spray it. That's also another method by which medical products are made. And so, to your point, there's different ways to create the medicine: spraying, bathing, or a couple of other ways to do it, and then infusion.
So am I correct in assuming that a product that has the medication infused is going to have more consistent dosing than like buying some gummy bears at Walmart and spraying them with something?
My assumption and your assumption are the same.
Does anybody else have any questions, comments? Yes. If you can come to any of these microphones and introduce yourself.
Hi, my name is Brad Sellers. I'm the Vice President and Legislative Director for the Cannabis Industry Advocates of Oklahoma, or CHOW for short. The marijuana industry in Oklahoma faces a lot of challenges right now and faces a lot of messes that are going to have to be cleaned up. But as we're moving forward, if there's a question out there, I should say there is a question out there among some people, does legitimate medical marijuana exist? And I think our witnesses today really should have dismissed that question. Yes, there are legitimate patients that believe they are benefiting from medical marijuana. The people around them believe they are benefiting from medical marijuana. And medical providers believe their patients are benefiting. And this community needs to be protected as we continue with reforms. There are bad actors that disobey the rules, ignore the laws, that improperly package products in order to hide them from law enforcement, to enable smuggling, etc. These are criminals, and they need to be treated as criminals, and they need to be prosecuted. So we need to keep the two sides clear as we're moving forward and trying to clean things up. The legitimate industry is your friend in this effort, and the illegitimate industry are our common enemy.
Thank you very much, Brad. I do want to piggyback on what he just said when we're talking about the legal players versus the illegal players, in that the Medical Marijuana Authority patrols probably isn't the best word, monitors and evaluates the licensed facilities, growers, whether that be growers, processors, dispensaries. The Bureau of Narcotics is who follows up and evaluates the non-legal facilities. Am I correct? Was that a correct statement to your satisfaction? So you hear a lot of things in the community. Well, the Medical Marijuana Authority needs to do this, but if this is not a legally licensed facility, then that's going to fall under the jurisdiction of the Oklahoma Bureau of Narcotics. And I will say that they are doing a phenomenal job. Some of my local law enforcement officers, not only in my district, but in other districts, are doing a phenomenal job at finding these bad actors and getting a lot of these bad actors out. So I just want to commend the OMMA and our law enforcement agencies from the OBN down at the job they're doing to regulate the industry, whether they be a legal or an illegal facility. And if anybody else doesn't have any questions or comments, I guess we're done. I want to thank everybody for attending. She's done great today, sitting through. I don't know that I could have sat still that long when I was 13, but I want to thank the presenters. I want to thank everyone that's here for whatever entity you represent, or just for your own knowledge. I want to thank everybody for being here, and I'll turn it back over to the chairman.
All right, we will take a 30-minute break before our next presenter, which is Representative Rowe. I want to thank everybody for coming out. There's a lot of interesting things going on in marijuana. New director at OMA, governor's on board, and some exciting stuff hopefully will happen this session. So thank you guys for coming out, and we'll be back at 10:30. Tobacco, and Controlled Dangerous Substances. From 10:30 to noon, we'll be going over youth access to tobacco with Representative Rowe. Take it away.
Thank you, Mr. Chairman. Thank you for everyone that's here that will be presenting and the ones that are just here listening to obtain information, and for also the ones that are listening online. We're going to be talking about youth access to tobacco today, and we're going to start off with Thomas Larson from TSET. And you guys can either stand up and present, you can sit down and present with one of the microphones. I'll just kind of leave that up to you. I just ask that when you get up to the microphone, if you would introduce yourself and who you're with. That way those listening online will know who you are. I'll turn it over to you.
Okay, thank you very much, and good morning. I am Thomas Larson. I'm the Director of Public Information and Outreach at TSET, the Tobacco Settlement Endowment Trust. And I'm going to talk to you a little bit about some of the data that we have on youth consumption, as well as some of the resources that TSET has available for parents, for educators, and for youth. So what we're really looking at after 2 decades of declining teen tobacco use is a new epidemic that's being led by vaping. You can see that in the last 2 years nationally, vaping has increased 218% among middle schoolers and 135% among high schoolers. In Oklahoma, more than 1 in 4 teens report vaping in the last 30 days. And this is especially concerning because, we know that brains are still developing until age 25, and so becoming addicted to a drug like nicotine in your youth really sets you up for a lifetime of addiction. Those kids who start vaping, they have a much higher susceptibility to later go on to use cigarettes or other tobacco products. And we know from more recent information that we have that among kids, Puff Bar is the most popular vaping device, with about 61% of kids having used Puff Bar recently. And yes, Puff Bar. It's Puff, P-U-F-F Bar. It's a disposable brand of vape. And then the second most popular is Juul, which is maybe a little bit more. It's been a little bit more established. Among kids, about 75%. Kids who are vaping, 75% would like to reduce their usage or quit, and they have tried, on average, at least 2 times to quit. Some more statistics here. Every year, 1,300 Oklahomans under age 18 become daily smokers. 88,000 Oklahomans under 18 will die prematurely from smoking. We know that 4 out of 5 kids who have used tobacco started with a flavored product. A lot of those vaping devices are available in a lot of fruit and candy flavors that mask the harsh flavor of tobacco. Almost 90% of adult smokers begin smoking at or before the age of 18. So that's really why addressing youth access is critical, because if you can keep kids from starting tobacco use until they're after 18, we would have a lot fewer smokers. Smoking kills more people than alcohol, AIDS, car crashes, illegal drugs, murders, and suicides combined. So if a lot of people think that tobacco is not a big issue anymore, the smoking rate has declined, it is still a huge issue. It kills 7,500 Oklahomans every year. And across the U.S., it kills about 480,000 people per year. These are some of the resources that TSET has available for Oklahomans. Our oldest, most recognizable program is the Oklahoma Tobacco Helpline. Since it launched in 2004, the Tobacco Helpline has helped about 475,000 Oklahomans. It provides free services 24/7. You can call. Every Oklahoman gets at least 2 weeks of free nicotine replacement therapy. You can have calls with a quick coach. There's texting support and materials that they will send to your house. Tobacco Stops With Me is an educational campaign funded by TSET that teaches Oklahomans about the dangers of tobacco use, as well as a lot of the deceptive marketing practices that the tobacco industry has historically used to hook users. And Shape Your Future offers free resources to Oklahoma families and educators, and it really encourages people to move more, to eat better, and be tobacco-free. So I'm going to talk a little bit more in depth about some of those resources. This is Tobacco Stops With Me, the Tobacco Stops With Me website, which is stopswithme.com, and it has a lot of resources for people who are looking to learn more about tobacco in Oklahoma and its effect on youth. There's a whole section there where you can find statistics and other information about tobacco in youth in Oklahoma. And for parents who are concerned about their kids, or for educators, there are conversation guides on here divided by age groups. So depending on the age of your child, you can go and you can get some talking points and some information about talking to them about the dangers of tobacco and vaping. This is the Shape Your Future website, shapeyourfutureok.com. And again, it has a lot of resources for families, educators. You can find under healthy eating, you can get information on recipes and meal plans. There are tips to be active. There's also an extensive section on being tobacco-free. Oklahomans can visit Shape Your Future and learn about protecting your family from tobacco, learn about tobacco-free schools, and also keeping businesses tobacco-free. Last year, TSET launched the Healthy Youth Initiative, which is comprised of several different programs. The first one here, My Life, My Quit, is a text-based service for those youth who have started vaping or using tobacco and would like to quit. We also are funding Swap Up, which provides nutritional information for students, encouraging them to switch out some of their less healthy food choices for healthier options. Down and Dirty is an educational campaign really aimed at rural youth in Oklahoma to educate them about the dangers of tobacco use and vaping, particularly smokeless tobacco. And Behind the Haze reaches all youth in Oklahoma to educate about vaping. Just this fall, TSET launched YALL, which is Youth Action for Health Leadership. And that's a program that's going to work with existing clubs and organizations in communities around our state and get kids active in health leadership and advocating for policies to create healthier communities. I mentioned earlier My Life, My Quit, and this is the website. Teens, youth who want help quitting tobacco or vaping, they can text to that number or visit the website to sign up for services. Like I said, this is a text-based service with a protocol especially developed for Oklahomans 13 to 17 years old. We know that kids, teenagers, are not going to pick up the phone and talk to someone on the phone, so we wanted to create a text-based service that's really geared towards those teens who are addicted and would like to stop. For educators, healthcare providers, parents who are interested in some materials, TSET has, you can go online and order free materials at tsethealthyyouth.com/order, and it has information on vaping, on My Life, My Quit. You can go and order any number of our posters, handouts, that kind of information free of charge. That is it. I'm happy to answer any questions.
Does anyone have any questions or comments? Representative Marty?
So last session, this speaks kind of to the pharmacist's role in this. Last session, we passed a bill that allowed pharmacists to bill for services rendered. Fancy way of saying provider status without the fight. Mm-hmm. Do you think TSET would be interested in figuring out a way to reimburse pharmacists for smoking cessation education, as well as maybe pushing to, because it's a fight anytime you want to get into expanding anyone's role in medicine, but pharmacists see patients 12 times a year, much more often than their physicians. But allowing pharmacists to prescribe smoking cessation products like Chantix or nicotine gum, so that it will be covered by insurances, as well as actually the education.
I think we would be very interested in talking to pharmacists about that possibility. You know, ultimately, all of our spending decisions are made by the board of directors, but we would be happy to have that conversation. Anything we can do to make smoking cessation drugs and materials more available to Oklahomans is something we'd be very interested in talking about.
Absolutely. Thank you. I appreciate you coming out today.
Thank you.
Any other questions? Okay, thank you very much. We appreciate it. Next, we have Elizabeth Cherry from the Oklahoma State Department of Health. Elizabeth, if you don't mind, once again, introducing yourself, even though I just did before you start, that would be great. Do you have handouts for us, or?
No, that's just me. Thank you. Good morning. My name is Elizabeth Sherry Mullen. I am the lead tobacco prevention coordinator at the Oklahoma State Department of Health. Before starting my talk today, I want to acknowledge the traditional and sacred use of tobacco among American Indian people living in Oklahoma. So today, whenever I refer to the use of tobacco, commercial tobacco, I will be talking about commercial tobacco unless otherwise stated. I will cover the current youth tobacco use in Oklahoma. I will also talk about the public health risks of vaping and strategies that we can use to reduce youth access to tobacco. I will briefly touch marketing and social norms, and I will also talk about the current youth access to tobacco efforts that are being done at the federal level, the state level, and the municipalities and jurisdictions. What are commercial tobacco products? Commercial tobacco products are products that are manufactured, mass-produced, and sold for profit by companies for recreational use and habitual use, whereas traditional tobacco products are products that are grown and harvested by a Native American or Alaskan Native for use such as medicinal purposes or traditional use for ceremonial purposes. So let's talk a little bit about why youth access to tobacco is extremely important. One of the things that Thomas just mentioned was the mortality, the potential for mortality associated with tobacco use. So when you think of tobacco use, if that trend continue, the trend of tobacco use continue in Oklahoma the way that it is right now, 88,000 youth will die from tobacco use. They will die prematurely. And what that means, to put it into perspective for you, it would essentially be the size of Lawton, the population size of Lawton, Oklahoma, will die because of tobacco use.
And over what time period, if you don't mind me asking?
They didn't really give a time period, but it's just a trend that they will die early. And usually with tobacco use, the morbidity and mortality starts like for lifetime tobacco, it starts like as they become like older adults. So it wouldn't be like they would die tomorrow. Yeah. But I can get that data for you. When it comes to tobacco use, we have to also be concerned about the morbidity associated with tobacco use. So for example, brain development. Tobacco use affects brain development. It can cause issues with attention. It can cause issues with causing inactivity in the brain cells. It all has to do with the nicotine use. It can also create issues with long-term issues with potentially increasing the risk of psychiatric disorders and also cognitive impairment. And we, as Thomas mentioned earlier, we know that there is an association between the age that a youth starts smoking. So for example, 90% of youth, if they start smoking before they turn 18, they are more likely to become an adult that smokes. And then we also know that there are long-term health and economic consequences of smoking. So for example, in Oklahoma, we spend $1.62 billion in healthcare costs when it has to do with healthcare costs related to tobacco use. $1.62 billion.
Is that annually?
Yes. And then when it comes to, when we think about that number, and if you think about the household, every household in Oklahoma, whether or not there's a smoker in that household, we pay $1,165. That money is paid to either federal tax or state tax, but that money is associated with tobacco-related disease.
Can I ask you a question, or would you rather wait till you're done with your presentation?
You can ask me.
So I had received some data that I kind of had a hard time wrapping my head around when you were talking about economic loss and such. That that was related to food insecurity, and that a lot of people who are food insecure smoke because of the effects on feeling hungry. Can you speak to that a little bit, please?
That's not really my area. I do have one of my coworkers that works on physical activity and nutrition, so I can definitely ask her to see if she can have some data that correlates. It does make sense because smoking does curb appetite, so it does make sense. But I will definitely ask her and then get that data to you.
I appreciate that. Thank you.
You're welcome. Okay, so in our next slide, I just wanted to kind of like chat about what tobacco control efforts are. So the CDC puts out a best practice, and during the best practice, it kind of like outline what tobacco control programs need to be. And what it does, for us to have an effective tobacco control, it needs to be able to reduce secondhand smoke. It needs to be able to help youth in terms of like helping them have access to cessation, helping them not getting hooked to the nicotine and being able to get hooked to tobacco products. But also, one of the things that it does, it looks at the disparities that occurs in tobacco use. There are disparities in tobacco use, and it looks at that and help and gives outlines, things that we can do to close the gap in disparities. So we're going to talk about the current youth tobacco use in Oklahoma. Before I talk about it, I just wanted to mention where our data comes from. And for the current youth tobacco use in Oklahoma, we usually, when we talk, we use two types of data. We'll talk about the National Youth Tobacco Survey or the YRBSS, which is the Youth Risk Behavioral Surveillance and System Survey. The National Survey, what it does, it's a yearly survey between kids between the age of the grade of 6 to 12, whereas the Youth Risk Behavioral Survey is biannually, and it's only high school kids, so from 9 to 12 grades. So when you are looking at the data that you are looking at is from the Youth Risk Behavioral System and Surveillance and System Survey. In 2019, Oklahoma had the fourth highest youth smoking prevalence among participating states. So if you look at the little graph there, you can see that even though we have decreased tremendously, because we started in 2003 with 26.5. That number has decreased, but we are still higher than the national average by having a tobacco prevalence rate of 9.1%. So in 2019, 30.8% of Oklahoma high school students reported using tobacco products. And when I talked about tobacco products, it's any type of tobacco product. So it can be whether or not they smoke, they use cigars, smokeless tobacco, or vaping. And as you can tell from the bar graph down there, back in 2017, that number was just 25.6%. And now that number has increased to 30.8%. And we have the data also broken down for you by race, gender, and grade. So I have a little bit of information about some of the public health risks of using electronic vapor product. So we've already talked about brain development. We know that sometimes effective the effective battery in a vapor product can potentially explode, causing bodily harm to the person using it and sometimes harm to properties also. We have looked at data, different studies that has been done, and one of them specifically has been done by Stanford University, and that study shows that teens that use a vapor products are 5 to 7 times more likely to get COVID than teens who do not use a vapor product. And then we also look at, we also have seen evidence that when somebody vape next to you, that you are potentially exposed to different things. You are exposed to different chemicals such as the nicotine that's in their vape product. You're also exposed to diacetyl, and diacetyl has been linked to popcorn lungs disease. You are exposed to the ultrafine particles that comes out of that vape emission, and you could potentially be exposed to toxic things such as toxic chemicals such as benzene, and even heavier chemicals such as nicotine. And of course, we want to mention also the risk of nicotine poisoning. So for young kids and adults, if they ingest the product or swallow the product, or sometimes if they just inhale the product, there is a risk of nicotine poisoning for them. And I do want to mention the severe lung illness that kids that has been shown in youth that have used tobacco vaping products essentially. In 2019, there was a lot in the news about EVALI, and it was essentially an illness in kids that has used vaping product. And even though that was linked to the THC in that product, it's still a public health risk that we need to be aware of. When it comes to the different things that we could potentially do to reduce youth access to tobacco, one of the great things that has already been done is the raising the minimum purchase age to 21. And other things that we can look at when we are looking at restricting youth access to tobacco is potentially decreasing the nicotine in cigarette to a level of where it's not addictive. Potentially limiting flavor availability to e-cigarette, repealing preemption. And what preemption is, it basically restrict or prohibit local jurisdiction to pass a law that is stronger than state law. And what that means essentially is that local jurisdiction, even if they wanted to prohibit or increase their enforcement of youth access, they wouldn't be able to do so. So although preemption is not always a bad thing, in the case of tobacco prevention, it is a bad thing. And of course, regulating e-cigarette and vaping product, regulating where those products are located in, at the tobacco retailers, making sure they are behind the counter, putting the same regulation that we have for combustible tobacco, having the same regulation for e-cigarette. And of course, having some sort of point of sale in retailer policies, and modernizing some of our licensing and enforcement policy also. The tobacco industry spends about $120.6 million annually to market in Oklahoma. And when you look at this type of marketing, it can be divided into about 4 types of marketing. So you have your promotion, you have your placement, you have your price, and then you have your product. So when it comes to promotion, in terms of promotion, convenience stores where 70% of youth shop at least once a week have more tobacco marketing and sell more cigarettes than any other retail store. In most retail stores, the checkout counter is the best place to encourage impulse buy. Because of this, tobacco companies spent over $702 million in 2014 to strategically place tobacco product and marketing materials in highly visible locations around checkout counters to ensure the most exposure and to increase sale. And when you look at the price of tobacco, so the average price of cigarette is about $6 a pack. If cigarette prices were to be $10 a pack, the cost would be prohibitive to youth buying the product. Therefore, the tobacco companies provide coupons, multi-pack discount, or price discount to alleviate tobacco costs. And when we think about social norms, so if a youth has one of their friends that smoke, or if like a parent smoke, they are more likely to be smokers also. So at the federal level, the FDA now regulates all tobacco products. They regulate, they have a ban on free samples. And also, the FDA just announced back in April 2021 that they have a proposed ban on menthol cigarette. And the reason why that's important is because a lot of time when youth use tobacco product, they'll start with menthol cigarette. And I do want to reiterate also that we do have Tobacco 21, and that law was passed in 2019 and became effective in 2019. And with Tobacco 21, that law applies to every state, every U.S. territories, every tribal jurisdiction. The only, and a lot of time people think there is an exemption for military. There is not an exemption for military when it comes to T21. So we have some things that we are doing in order to curb or prohibit the youth access to tobacco. So when we think of, we have of FDA contract at the tobacco division at our State Department of Health. And what they do, they will complete compliance check and retailer education visit. And those retailer education visit will help educate retailers and clerks to stay out of trouble and to follow the law. And then, of course, we have the Oklahoma Department of Mental Health Substance Abuse Services. They have SINAR, they have to enforce the SINAR Amendment. And what the SINAR Amendment is, it was done by an Oklahoman representative, Mike SINAR. And what that does, it basically gives ODMH the power to enforce the law when it comes to youth access to tobacco, and they have to limit the successful sales of tobacco product and have that sale be under 20%. And they work in conjunction with ABLE to be able to do this enforcement. And of course, we have, in terms of retailer education, currently the State Health Department is working on developing a website called Validate, where it will be a platform where retailers and clerks can come and get information about the law and get information about Tobacco 21, and to be able to stay educated and know what's happening whenever the law changes. And we have a project also called Project Chat. That project looks at retail density, and it looks at the point of sales in the community. And of course, all the time, there are always different efforts happening in the community, such as local ordinances that jurisdiction and municipalities can pass to help them enforce the law, as long as that is within mirror what is in the state law. And of course, a lot of places passes voluntary tobacco policies, and the goal of those voluntary tobacco policies are to reduce secondhand smoke. So we just chatted about Project Chat earlier, and it's basically combating heavy advertisement of tobacco. And as you can tell, and this is the data from 2021, and there is about 1.1 tobacco retailers as a whole, 1.1 tobacco retailers as a whole in 2021 per 1,000 population. So back in 2019, that number was only 0.96. So we have seen an increase in that, and that increase is all over the state of Oklahoma. And I wanted to just kind of like point out what other states are doing when it comes to tobacco effort to reduce youth access to tobacco. And for example, Arkansas and Louisiana, they have required retail licensing to sell e-cigarette. And then for Texas, instead of like punishing youth that are using tobacco product and by letting them have a criminal record, what Texas does, they have a program called Texas Youth Tobacco Awareness Program, and a youth can be referred by their court, their school, or by a parent or guardian, and then they go through the program, and it helps them. They can bring that certificate to the court, and it essentially helps them not to have a criminal record. So, one thing I do want to mention, when it comes to, there is no safe level of nicotine. There is no safe level of tobacco use. So if we can do something right now to impact and reduce youth tobacco use before youth becomes 25, the likelihood that they will become addicted to tobacco will be slim. Any questions?
Thank you very much. Does anybody have any questions? Representative Marty has a question.
So when it comes to placement in the stores, and I don't go in looking for tobacco or e-cigarettes, but they're typically, at least on our side of the state, on my side of the state, behind the counter. Are there lots of, I'm seriously being curious, are there a lot of convenience stores that have these things that aren't behind the counter? Because you have to be 21 to buy any kind of tobacco product in Oklahoma, whether it be e-cig or cigarettes.
Yes, I wish I had pictures, because when they did Project Chat, and that's something I can potentially share those slides with you guys also. One of the report, basically what it was, a lot of four students from OU contracted with the state health department, and they went on the state they have an assessment called the STAR assessment, and it looks at essentially where things are being placed. And a lot of those pictures did show that things were not placed where they needed to be, including e-cigarette, where there were a lot of things that were placed near the ice cream fridge in the front, and it was exactly at eye level to a child. So essentially a child could, if you're going to get some ice cream, it's right there and you can see it.
Okay, that's interesting. You mentioned the Texas Educational Program for youth offenders. And again, this is going to sound silly, but I was from a small town, and I guess not a lot of kids got really in trouble for much. Is it a big thing that the police are actually prosecuting underage smokers? Like, is there really a criminal record that goes along with that, or is that more like a "don't do this, call your parents" type thing?
I'll get into that here in just a few minutes if you'd like
Okay.
to do so.
Yeah. Okay. That'd be great.
We have a class that we're offering now that we're going to talk about here in just a minute. That we'll talk about something that we're offering that they can do, and some different programs that we're offering to help do that, for sure.
Are there any other questions or comments? Elizabeth, thank you very much for coming. You had some great information. We appreciate it.
Thank you.
Okay, next we have Eric Smoot from the ABLE Commission, and I think he said he had some answers to the questions that we had just a minute ago somewhere in your presentation. So,
For sure.
Turn it over to you.
Yes, I'm Captain Eric Smoot. I run the Training and Education Division of the Oklahoma ABLE Commission, which also includes compliance over tobacco and alcohol. Do you want me to go ahead and answer those questions, or do you want to wait till I get to it in the PowerPoint? Okay, perfect, sir. So we do have several different efforts that we're working on through the ABLE Commission to deal with tobacco and vaping as they come along. Obviously, enforcement is what we'll talk about first, because it's what we most expect from the Oklahoma ABLE Commission. But we also are doing some education efforts, some collaboration efforts, and prevention efforts. We've realized that none of these on their own is going to work. We truly have to do all of these different efforts to work, and working with these different groups has been helpful to us in doing that. And so I'm going to kind of go through the different things. I'll start with enforcement first and then go from there. I'm sure you're all aware of the law in Oklahoma for selling to a minor. If anybody that sells to somebody under 21, whether they be sell, furnish, nicotine, tobacco, or any vapor product, it's a crime in itself. The penalties is a $100 fine for the first offense, $200 fine for the second offense, and $300 fine for the third offense and each following offense after that. If a business sells to a minor more than 3 times in a 2-year period, the tax commission should suspend their license up to 30 days of the first offense and up to 60 days after a fourth or subsequent offense. So basically that's how that penalty works, as that goes down the line. We report to the tax commission every time a business sells, and so they track that, and the business should be suspended if in 2 years there's more than 3 offenses. But that part of the business side is handled by the tax commission, not by the Able Commission. On this minor in possession, it's same thing. A minor caught in possession of, or anybody under 21 now, caught in possession of a tobacco, nicotine, or vapor product, it is a crime. And if they're caught, first offense by law is not to exceed $100. A second offense not to exceed $200. And if they don't pay those fines or they don't call us to take care of those violations, their license is suspended by the Department of Public Safety, or they're not allowed to get a driver's license by the Department of Public Safety. Now, this is where we've taken some extra steps. Our legal assistant, what she has realized through this process is that that fine really generally comes back to, because our legal assistant deals with these calls that come in from, what happens is, for the minor charges that we get, 95% of those come from schools. In Oklahoma, we have a program where if a school catches a minor in possession of tobacco or a vapor product, they can write a ticket through the Able Commission. It's basically a form they fill out, and it can be done by a principal, a teacher, whoever the school authorizes to do that. Because what we were realizing is that a lot of these schools were having trouble getting an officer to actually come to that school and do anything about it, but the schools were getting into issues. And we'll talk about where those numbers are here in just a little bit and why we realized it was a problem based on the numbers I'll show you. But what she's realized is the parents were normally calling, paying those fines. And so we looked at some different ways of trying to handle that. And so what we started doing about 1.5 years ago is our general counsel decided they would offer the parents, if you would rather, instead of paying a fine, you can let your child do community service. And so they let the parents sign off on it. And, a lot of these kids come from smaller rural communities. So they would let the parents decide, if you want to make them mow the neighbor's grass for 10 hours, we would set it at 10 hours, but literally they could decide in their community. We weren't making them come to Oklahoma City or go to Tulsa or do anything else. It could be whatever they could find in their community. But if the parents would sign off, they did 10 hours of community service, they could do that in lieu of, hoping that would make an impact. We've just recently went into a situation with the Department of Mental Health we've been looking at for months, but got it started a couple weeks ago with Aspire. So now we have a new program, which is a tobacco and vaping cessation program. So now the first offense is they'll go through this tobacco and cessation program to hopefully help them quit. It doesn't cost anything. It's about a 3-hour class that the youth can go through for their first offense. We're hoping that's going to make a difference. That's kind of what we're looking for. We're trying to give them other options. We know that just paying a fine is not helping these kids stop using tobacco or vaping products. So now they have the cessation program, which is obviously our first recommendation. They could still do community service. They can still do the fine if they just insist that's what they want to do. Second offense, we're still going to use community service right now because based on the program we have, doing it twice doesn't benefit. But we have kids right now this year already that are on their third offense for this school year. So it's an issue. Right now we have over 30 school districts that are writing these tickets through us. But we'll talk about those numbers here in just a minute. So that's kind of how we judge our issues that are going on through the state. I'm not going to show you a lot of different numbers. I'm going to show you the numbers that we see each year and what that means to us. So when we look at where we're doing our enforcement, the sign-our checks that Elizabeth just talked about, those are checks that we do each year to base kind of the state average. They're separated across the state, so we're actually hitting almost every community in the state, trying to get an average of how many clerks are selling to minors and what the state percentage is. That gives us numbers for that. We do checks through the U.S. Food and Drug Administration. We did these several years ago, and they put a lot of requirements on the state, so we'd stopped, but we just are starting that back up again. And that'll be almost 2,300 checks per year that we'll be doing to make sure businesses aren't selling to minors and that they're following those laws like you asked about, sir, like making sure that the cigarettes are where they're supposed to be, that they're not, out where kids can just grab them and walk out with them, that they're actually behind the counter. So that'll be a part of that. Or enforcement through the school systems. And then just the additional checks that we do for tobacco and vape, especially on complaints, where we get a call that, hey, this store's selling to minors and those type of things, and we make sure we follow up on all of those. So sign-on rates, they've fluctuated. In 2017, only 13% of businesses were selling to minors. In 18, it went down to 82%. It was right at 82% in 19, went back up to 87% in 2020. Now in 2021, we weren't able to do those checks based on COVID. So it limited, sending the minors into the stores wasn't the safest idea in 2021 with everything going on. Now we're talking about fiscal year, so we're talking about June to July, and that's why doesn't seem like 21 would be the year, but it was for the physical year. And then back there this year, we were at 83%. One thing that changed in there, remember in Oklahoma in 2020, we changed the law from 18 to 21 for tobacco. So we think some businesses we were reminding businesses, hey, listen, 18 is not the age anymore. You got to be 21 to sell tobacco. So maybe there was a learning curve in there on that. So we dealt with that. On the Food and Drug Administration checks, like I said, we're just getting that kicked off again, but that's going to be approximately 2,500 checks per year. So that'll be a lot more. We will have 3 agents full-time assigned to that FDA program. So that will be a lot more additional checks, making sure businesses aren't selling to minors across the state. And we're still working to complete that process. But this is the one I wanted you to really look at on the schools. I thought this was very, very interesting because, vaping really kind of took off in that 2017, 2018 era. So in 2015, 82 violations came to us from schools. In 2016, we got 74. 2017, we got 98. 2018, we got 186. 2019, we got 537. 2020, with COVID, we still had 309. And even this year, on the school year 2021, we're at 409. And kids, you got to remember, weren't even in school most of this school year, on this physical year, until probably August, right? A lot of kids were still out until last year, and we're still at 409 violations as of the end of October. So we're getting a ton more. 2019, 2020, and 2021, we more than tripled what we've been getting for tobacco violations at schools. So more kids are using tobacco and vaping products in school than we ever saw before. We went from the 80s and 90s into the 500s, 400s, and 500s. So that's the numbers that we're seeing now from schools on tobacco violations. So those numbers have definitely shot up. So that's a lot of youth using tobacco products, vaping products. And a lot of that has been the vaping products that we've been seeing the increase in. We talked about our compliance checks rates, and they have been going down, 85 and then 74 and 68. And we think a lot of that's because of COVID. The less time we're out checking businesses, the less often we're able to go into the businesses and make sure they're selling to minors, which obviously reduced some during COVID. The compliance rates go down. The businesses aren't checking licenses as well, aren't checking IDs as well. So we know we need to be in there more, and we're hoping these new programs that put us in those stores more is going to be more reflective of that. But our education efforts, we talked about the Aspire program, which is the new program that we're doing when we get a violation from the schools, which will actually be the program the kids will go through for 3 hours. Hopefully that education will help them be a little more instead of a monetary fine. Maybe that will help them with that. Retail education visits, we're working with the Oklahoma Department of Health. On top of our regular compliance check visits, we're going to do some visits to the areas that don't do very well that we're looking at that are failing more compliance checks. And whether they fail or not, we're going to take some education in. We're going to send a kid in, find out if they sell to a minor or not, and give them education on how to check IDs. Talk to about better ways of looking for minors, looking for fake IDs, those type of things. And hopefully that's going to help in some of those areas where we see the least amount of compliance. So that'll be a different education effort. We're doing presentations at schools. That has really died off since COVID started. The schools are much less likely to let us come in. We've seen two huge things in this. One is it's always positive to have a police officer in front of kids. We've seen very much success in that program. Secondly, I'm telling you, even the cessation programs that we've talked to people about, if the kids don't want to quit, they don't seem to be working very well. The parents can want them to quit all day long. The teachers can want them to quit. What seems to work the best is if we go in and we talk to these kids and try to get them not to start. Try to get in there early, because we're getting tickets from middle schools and high schools for vaping and tobacco. I mean, the middle schools are coming in not quite as strong, but almost as strong as the high schools. So if we get in there, if I'm talking to sixth graders and seventh graders, and I just start out talking about choices and consequences, right? Every choice you make has a consequence. And if you make the choice to use tobacco or vaping, you may not be able to quit. We talk about the consequences behind that. Just like I talk about the consequences behind, you run down the hallway and you hurt somebody and you have to go to the principal's office. But anything to try to get their attention, to get them not to start, I think is the most successful. So we really believe it's important that we get officers in those schools, talking to those school groups. And like I said, we were very, very successful about that before COVID. It's been a little harder since COVID started. And we've been doing some training for TSET on having them go into stores, do some retail education visits, sending minors in. The more times people are talking to businesses about not selling to kids and how to make sure they check IDs, it's going to be successful. So we think that's a very important program. And then prevention, working with the tobacco work groups, working with the groups that are here behind us on ideas, on plans, on moving forward, on what we can all do together. And then media ride-alongs. We just did because our compliance rate has been low on tobacco, we just took media with us on compliance checks in Tulsa and Oklahoma City on tobacco. And when they sold, we let the media see that. And hopefully if more and more clerks and more people see that we're out doing those checks, less of them will sell to minors. So we are trying to do media ride-alongs and those type of things to just get the word out about not selling to kids and stuff on tobacco. That's what I've got. Hopefully it was helpful. I hope I gave you some information you could use.
Thank you. I do have a couple of questions.
Ma'am.
I'm from, rural community. I was raised in even a smaller town that has less than about 400 people there. So do you see that selling to minors in convenience stores in smaller towns is worse? And the reason I ask that is it because kind of everybody knows everybody and, oh, well, she's my friend, I'm going to go ahead and sell to her. Do you see that happens more in these really small communities that probably don't get a lot of visits by law enforcement? I mean, some of these towns don't even have police officers. So, it seems to me that this would happen more in small communities than larger communities.
We've looked at it that way, and we can't show that it does. Now, obviously, if I'm in a county and there's only 5 stores in the county and 1 sells, then it looks like 80%, or 2 sell, then it looks like it's only 60% compliant. But that's not really a fair advantage when you're looking at a county that's got 1,000 locations, right? But we haven't seen any trends that show that way, just based on the compliance checks we did. Now, the problem you run into, like you just said, though, when we do a compliance check, we bring a kid from somewhere else and we take them in because we don't want a youth they know to be the one that goes into the store, obviously. But you're right, it is very hard to tell if they know the child or they know who the youth is and they come in every day, whether they would actually sell to them or not. And that's very hard for us to mimic that to do a check with. So I think you're right, that probably could be an issue, but it's very hard for us to mimic that in a check because we're obviously bringing somebody in they wouldn't know because we would never want them to sell to somebody just because they knew them or something like that. So I do think that's a lot of issue because we do hear that from parents. Parents will call us and say, hey, this store's selling to our kids, and we'll keep sending kids in there and we can't get a buy. And the parents say, well, yeah, because they only sell to people they know. And so it's very hard for us to mimic that or fake that to try to catch them selling to minors. So I do think it happens, but we have a very hard time proving it a lot of times.
And then I have one more question. And I don't know if this would be for you or somebody from TSET, but are there any kind of incentives to businesses to not sell to minors? I mean, and I hate the fact that we have to sometimes incentivize people to do what's right, but is there any kind of incentive programs, these convenience stores or these entities that do what they're supposed to do and don't sell to minors?
we don't have any. Obviously, I mean, if they got tickets from us or FDA, it would be very expensive. So, I mean, I would hope the incentive would be not having to pay or not having to deal with those programs. But we don't have anything positive we can give them now. We are doing these retail education visits where we do go in and say, great job, you didn't sell to the minor. But I don't know that they see that as an incentive, right? I mean, it's a positive here, great job, but I don't know that they may not see that as an incentive.
Thank you. Does anybody else have any questions? Representative Marty?
I appreciate the time.
Yes, sir.
That you're spending here with us today. Couple things. What are the rates of selling tobacco to children versus alcohol?
So right now, our compliance rate for tobacco on Sinar is actually better than it is on alcohol. When we did the state average for Sinar this year, we're 83%. When I look at what our rate was for alcohol this last year, it was a little below 80%. Now, we did do some things different on alcohol this last year. For alcohol this year, what we did differently was we did check some curbside locations, quite a few, and we did check some delivery, which was obviously new this year, with curbside and delivery for alcohol. And so those numbers were a little lower because they were brand new, and we were testing some of those things to make sure those type of businesses that were doing that weren't selling to minors. So this year, the alcohol number was actually lower than our tobacco number. Generally, they stay about the same, but this year the alcohol number was lower because of that. But we did do well over 200 checks of just the curbside and delivery locations just to make sure that those new types of delivery and curbside locations were not selling to minors, because we wanted to make sure that wasn't creating a new problem we were going to have to deal with.
Okay.
So did a lot of enforcement around that.
Okay. In this building last session, it was tried to convey to me that you guys don't care as much about tobacco as you do alcohol, so there's a lot more sales to kids in tobacco than alcohol. So I'm glad to hear that's not happening. I think someone had a bill last year, or at least it was talked about scanning an ID before you could purchase tobacco. Is that something that you guys have looked into, or was that just whispers in the hallways?
We've looked into some scanners, Freddie's. The problem is, I can show you some IDs that I have in my car, sadly enough, that the new IDs that these fake IDs these kids are buying from across the country, from other countries that come into the U.S., they will scan. I can take these fake IDs that are in my car now that we took off kids in bars. I can take it to the convenience store down the street. They can put it on their scanner, and it will still tell them they're 21. So my important part of that is they still need to take the time to look at it and make sure it says. Just scanning it is not enough every time. A lot of times they scan the ID and overwrite it. So I think scanning is important. It's a great tool, but it's got to be a matter of looking at it as well. So I don't think that just dictating the scanner itself would be just enough, but I do think it's a great tool they could use as a store. But I think mandating that's the only way you do it wouldn't just fix the problem on itself.
Okay. One last question is, you mentioned there was 30 schools that participated in the, hey, we caught this kid and he needs a ticket or education or community service. Any thought in mandating that schools do that and punishing schools who don't do that?
Well, we have never encouraged them. I think some schools do it through suspension. I think some local police departments, some have school resource officers that are more than happy to come in every time and write that ticket, and they do it municipally, and that works out great for them. I think some schools do it through in-house suspension. It works good for us if they want to use us, if they have a program they think works better. We just want to partner with whoever needs us. We want to be beneficial to whoever needs us to do the right thing. If this works for them, we want to be there for them. But I wouldn't want to penalize them if they have a great program that already works either. So we just want to partner with whoever we can. We want to reduce youth access to tobacco. Whatever we can do to do that, that's what we're there for.
Awesome. Thank you.
You're welcome, sir.
Any other questions? Okay, thank you very much. Next on the agenda is Wendy Lawson from the American Lung Association.
Hi. And before I start, I wanted to mention, just in addition to what the ABLE Commission said, the American Lung Association actually has a program that the schools can go through, and they train, and it will eliminate suspension and penalty on the child who was caught with a vaping or a tobacco product, and that it's a 4-class, 1-hour session for the kids to go through, and then they can have another chance. So they also offer that. All right, so My name is Wendy Lawson, and I live here in Oklahoma. I am a board chair of the Southwest Regional American Lung Association. I'm also sitting on the local board, and I'm a part of the Regional Relations Committee for the American Lung Association. I'm a public health professional with a graduate degree focused in chronic disease epidemiology. In addition, I am a licensed respiratory care practitioner, and my greatest job is the mother of 2 children who are in college currently. I want to thank, first of all, Representative Rowe for her attention to this incredibly important thing. Youth tobacco and e-cigarette usage is a problem, and we've seen it as a problem, and we thank you for focusing in on this today. My job here today is to help you understand the impact of tobacco addiction. My journey as it relates to tobacco started in my youth with my grandfather. He had a carrier franchise in Tahlequah, Oklahoma, and he was also a cattle rancher, and he had this beautiful ranch that backed up to the Illinois River. He was one of the hardest workers that I have known. He worked hard, he raised my parents, and I loved to visit the ranch and ride the horses. He was also a smoker. He started smoking when he was young, whenever we didn't know the cost of smoking, when those things weren't known, but they're known now. And although he quit smoking, it was too late. The changes to the cells of his lungs had already damaged, and 19 years later, he was diagnosed with lung cancer, and he died 3 months after diagnosis. I miss him. I miss his words of wisdom. His story is not unusual. Sadly, I bet everyone sitting into this room knows someone just like my grandfather. Each year, Oklahoma says 7,500 adults, just like my grandfather, that die of smoking-related illness. Almost all started when they were young. They thought it was attractive, or it wasn't harmful. They didn't know that they would have a lifetime addiction that would follow. We know that nicotine addicts. We know that the tars and the chemicals you inhale can destroy your body. We know that anything you inhale into your lungs besides clean air will impact your lungs negatively. These are undisputed facts. As an asthmatic myself and a lung association volunteer, my kids, when they were home, knew how important it was and the dangers of tobacco. They knew that lung health was very serious to me. I was really proud to hear them whenever they were talking to their friends about e-cigarettes and tobacco products, and they would tell them about the dangers. But the thing that really concerned me as I heard these conversations that they were having with their children is that the responses of their friends were things like, oh, but it's just an e-cigarette, it's water vapor. It's not going to harm me. It's not like smoking a cigarette. I'm not putting all those toxic things in my lungs. They saw the colorful, fun marketing, they saw the flavors, and they put these e-cigarettes in a completely different category than that of a cigarette. They know cigarettes are bad, but e-cigarettes, they don't think it's so bad. These products referred to by the tobacco industry as nicotine delivery systems, they actually say that, not only contain incredibly addictive nicotine, but a number of toxic chemicals. These chemicals cause lung disease, lung injury, asthma, and all sorts of bodily harm. Several studies found a chemical called benzene in e-cigarettes, and you heard that previously. It's also found in car exhaust. Or what about acrolein? It's a herbicide. It's also known to cause irreversible lung damage. While kids are being told that this is just vapor, they're actually inhaling aerosolized toxic chemicals into their lungs. Now, if there was an internet craze that children were inhaling paint or herbicides, we wouldn't hesitate to get involved. We would jump at the chance to take action. We wouldn't hesitate. But when it comes to these sleek devices with the fancy marketing, the tasty flavors added, we kind of shrug our shoulders and say, well, you know, kids are going to be kids. But that's why I'm here talking to you, is because kids will be kids, and we need to help them. In my role with the Lung Association, as a board member and as a clinician, I focus in pulmonary health and wellness. And I'm often asked to go to schools to talk to children about e-cigarettes and about smoking cigarettes. When I drive to their schools, one of the most concerning things that I see, more often than not, is within half a mile of that school walking distance, there is an e-cigarette store. Once inside the school, I'll ask the children, raise your hand if you feel like smoking a cigarette is bad. And almost every hand goes up without hesitation. They know cigarettes and tobacco products are dangerous. But when I ask, do you feel like e-cigarettes are like cigarettes? They hesitate. They pause, and not nearly as many hands go up. The kids don't know the dangers. The parents don't communicate those dangers because likely they don't know them either. And as a result, we're seeing significantly more children using e-cigarettes than traditional cigarettes and other tobacco products. We've made such incredible progress with our youth tobacco and cigarettes. Just in the past few decades, we've seen a drastic decrease in the usage of cigarettes. But in a few short years, e-cigarettes have undone all of that. Vaping products have taken us back to where we started. In fact, there are 3 times more usage of e-cigarettes than tobacco products in this category. And we heard earlier from the health department that 30.8% of kids are using. That's a lot, 30.8%. One estimate estimates that, and you heard this previously too, 88,000 kids that are now alive in Oklahoma will die prematurely of smoking-related illnesses. We're back to where we started, and I don't feel okay with that, and that's why I'm here. The American Lung Association is very concerned that we are at risk of losing another generation to tobacco-caused diseases as a result of e-cigarettes. The Lung Association's annual State of the Tobacco report finds that while we're doing an okay job at helping people quit, we are dropping the ball when it comes to preventing them from even starting. And that's where it starts. The rapid increase in youth usage of these products, the colorful marketing, the flavors like gummy bears and cotton candy, the vape stores that seem to be on every corner that are difficult to get into every single one of them to make sure they're not selling to younger minors. This is not going to end well unless we do something. I want to close with a story of a patient that I worked with personally. Like my grandfather, he began smoking as a very young individual. He works here in Oklahoma. He's a truck driver. And when he came to our clinic, he told me that he smokes 6 packs a day. Let me say that again, because this is incredible. 6 packs a day. That's 120 cigarettes every single day. So when I questioned him and said, wow, I mean, how did you get started? He said, I would love to quit. My whole life I've wanted to quit. But my addiction began when I was 6 years old, and I stole cigarettes from my neighbor, and I would hide them in a coffee can in the back of my yard so my mom didn't see. He got addicted, and he said the effects of nicotine on him have been lifelong. When I saw him, his lungs were destroyed, and he was going to die. And he was sad because he wished he could reverse all of that. This was all due to something that he started innocently whenever he was a kid. If action isn't taken to address youth e-cigarette usage, how many of our children are doomed to that same future? A future of addiction and a future of early death. We can do better, and we owe it to our children to do better. The Lung Association of Oklahoma strongly encourages the legislature to take bold action on behalf of our kids. Thank you.
Thank you very much. Do we have any questions? Representative Marty?
So my question would be, what bold action are you recommending? What can we do? I don't know if you've been around the last couple of years. I'm guessing so.
We will.
Okay. I'm always one ahead. My bad.
That's okay.
I'll wait patiently.
That's great.
I'm known around here for my patience.
Thank you very much. Okay, so next we have Sarah Riven from the American Heart Association, and I want to thank her because she's the one that I've been working with at getting this study put together, and without her, this probably would not have been possible with her help in organizing everything, so thank you.
No, thank you. Thank you so much, Representative Rowe, as Wendy said, for talking about this really important issue. Thank you, Chairman Marty, for having us all today to talk about this issue. And my goal is to talk about some of our policy recommendations, specifically from the American Heart Association and the American Lung Association, that we believe would help us combat this epidemic. I did not introduce myself. I am Sarah Riven, the Government Relations Director for the American Heart Association. Okay, which button do I push? This one. Okay. So before I start, I did just want to reiterate that this is a deeply personal issue for me and for most of us sitting up here today. As Wendy talked about, we all know a story of a friend or loved one who has had a poor health outcome or died because of tobacco and nicotine consumption. I have a great friend from Shawnee, Oklahoma, who started smoking at 13, as did many of his peers. We know that most smokers who quit want to quit, again, as Wendy talked about, Dr. Lawson talked about. And similarly for my friend, it wasn't until he was well into his 40s that he was able to do so. And that is just too common of a narrative and why we're here to talk about this issue. So you've heard a lot of discussion about the dangers of tobacco. I wanted to be sure to highlight those dangers specifically related to heart health. We know that smoking is still the leading cause of preventable death in this state. And although we think a lot about lung disease, cardiovascular disease kills more smokers age 35 and older than lung cancer. The symptoms include narrow or blocked arteries in and around the heart, high blood pressure, stroke, and heart-related chest pain. I'm not going to try to say the scientific term. Again, we've also heard that 7,500 adults die each year from their smoking in our state, and we know that there are 88,000 kids who will die prematurely at the current rates of use. We've also seen other pictures about some of the products we're talking about. This highlights some different e-cigarettes as well as some of the newer emerging products, all made by the tobacco industry. In addition to tobacco, we know that nicotine has poor effects for both heart and brain health that I wanted to touch on. So, nicotine can cause increase in blood pressure, heart rate, flow of blood to the heart, and a narrowing of the arteries. And it can harden the arterial walls, which can lead to a heart attack. And again, this is nicotine that we're talking about. Additionally, we know, again, that there are poor effects on the brain from nicotine. And because nicotine is so addictive, that's why we know that 3 out of 4 teen smokers end up smoking into adulthood. and that those young people are particularly likely to become lifelong users. Tobacco use, nicotine use, increases the risk of major depressive disorders, panic disorders, and addiction to other substances, as well as academic problems. And we also know that a lot of these products contain even more nicotine than cigarettes. So, for instance, one vape cartridge can contain as much nicotine as an entire pack of cigarettes. And we know of youth who will consume 2 to 3 vapes a day. So that is a huge amount of nicotine that young people are consuming. So you've heard a lot about some of our solutions to these really important issues. The first is, as you've heard, we have to think about how we're educating youth, parents, retailers, everyone about the risks associated with these products. And as I've said, I am also going to talk about some of the policies that we know to be effective when it comes to curbing the attraction and the accessibility of these products. I also just want to reiterate, we know that the tobacco industry spends $120 million every year in Oklahoma on marketing, and so we take it very seriously that we need to find solutions to and tools to combat that influence. So the first topic I wanted to touch on related to policy is tobacco taxes. This is a little bit of the lay of the land. In 2018, we raised cigarette taxes to be $2.03 a pack. At the time, that made us the 18th highest in cigarette excise taxes. Of course, since then, some other states have increased their taxes, and we don't have the new rankings, but we've dropped a little bit. There is no tax on e-cigarettes in Oklahoma. The last tax on other tobacco products was passed in 2005. And from our perspective, we actually took a step back in 2021 by passing a new law changing the definition of which products are taxed. Yes, Representative?
Can I ask you a question real quick? So do you think the fact that there's no taxes on e-cigarettes, which makes them cheaper than cigarettes, is leading to the vaping craze in part?
Yeah. So the reason, thank you for the question. The reason in part why we know that e-cigarettes are attractive, in addition to the flavored nature of them, the marketing, et cetera, as you alluded to, is price. I think it was Elizabeth who said youth are especially price sensitive. And so when a product is cheaper, it becomes more attractive to kids who are priced out at a certain price point. There are certain products, for instance, that might be $5 for the product. Well, if there's a 60% tax, suddenly that product is going to be more like $7 or $8. That is a significant price increase that suddenly really makes that product much less accessible to someone who's young. So yes, if the product stays around $5, that's a much different conversation. And like you've said, we know that's exactly the reason why tobacco taxes are so effective. I did want to talk broadly as well about why tobacco taxes work beyond the price disparity. It's a win-win-win. First, for health, we know that tobacco taxes deter consumption. As we've said, a significant tax makes those products much less attractive to consumers, and therefore they're going to consume fewer of those products and keep their health. Secondly, we know that they're a great tool for increasing revenue to the state. Even as consumption goes down, that higher tax does bring in additional resources. And then the third way that they're a win is from a public opinion standpoint and a political standpoint. People like the idea that we can increase revenue to the state through tobacco taxes. So they are a great tool that we have in our tool belt for, again, preventing new users from starting and addressing this consumption issue. I also wanted to reiterate that when we think about consumption and differences in price disparities, those taxes and the increases in price are most effective with new users. And of course, when we talk about new users, we most likely mean children. The reason is if you are already addicted to these products, the unfortunate truth is you are much less likely to be deterred by these changes in price. If you have a product you like, you will continue to consume it. But again, when we actually increase these prices, we are able to deter new users and youth from starting, which is the most important goal I think that we all have. So again, tobacco taxes have the greatest effect reducing smoking among those ages 18 to 14, or I can't read, 18 to 24. And because most adult smokers pick up the habit as youth, again, we're able to deter that habit by adding those taxes. Were there any other questions about taxes? Okay. The second policy I wanted to be sure to address, again, others have alluded to it, is the way that we treat purchase, use, and possession among minors or people under age 21. Ooh. So this spells out, as Captain Smoot discussed, the penalties on young people caught in purchase, use, or possession of products. We call it PUP laws. The American Heart Association is very enthusiastic about reforming these penalties because we know that these penalties don't actually work. As Captain Smoot talked about, we need to add an educational component. And in fact, in a lot of cases, these laws can do more harm than good because they are inequitable and they disproportionately affect certain populations, including low-income Black and Hispanic youth. So our recommendation, and what we'll hopefully be working on with you all, is to, instead of this punitive structure, as Captain Smoot talked about, we need a system that encourages education and potentially community service in order to actually look at how youth are consuming these products versus, those fines. We talk a lot about this, Captain Smoot and I, and, if you're a family that can afford it, it doesn't hurt you as much to pay a $100 fine. It doesn't change your behavior as a child, but if you can't afford that fine, there are really severe consequences, and instead of that disparity, we want to ensure that there are actually measures in place to help curb consumption. And the last policy I wanted to be sure to highlight is related to tobacco retail licensure. That's our fancy, coined term for just looking at how we license retailers when it comes to tobacco in Oklahoma. So as you can see, the current cost of a tobacco license is $30 for 3 years. There's no license required to sell e-cigarettes. I would never put words in Captain Smoot's mouth, but we also discuss a lot how many more resources are needed to ensure that we are doing all of the compliance checks. I know you asked about alcohol versus tobacco. Needless to say, we just want to ensure that across the board, the ABLE Commission has the resources needed to be doing the very important checks to make sure that kids do not have access to these products. And so to that end, I did want to mention as well that the cost for a license to sell beer is $750 per year in Oklahoma, and the cost to for a license to sell wine is $1,250 per year. So you can see that there are, again, I don't want to speak for the ABLE Commission, but far more resources that enable them to do alcohol checks than there are for tobacco compliance checks. I also wanted to mention that 1 in 6 middle and high school students report obtaining e-cigarettes in a vape shop. There is no license required to sell e-cigarettes in a vape shop. There's no regulation on those shops. It means there's no education being provided about how to check their age or any other mechanism. Additionally, 1 in 10 middle and high school students under 18 report obtaining e-cigarettes at a gas station or convenience store, which again just shows that we need to ensure that retailers have the resources, including education, so that when young people are coming into their stores, they know what products require proof of age, et cetera. And with the changing landscape, the age of sale being raised to 21, et cetera, that's a key part of the licensure as well. So that was what I was here to discuss with you all today. Thank you so much again, and I'm sure there will be questions about some of that information.
Are there any questions? Sure. Representative Marty, he always has a question.
Why not? So, I'm guessing you've been around the Capitol a little bit when bills about tobacco are up. It gets pretty exciting around here.
Oh yeah.
When we talk about increasing the taxes on whether it be e-cigs or tobacco in general decreases use. Obviously, the first rebuttal of that is, you increase taxes, you decrease use, which decreases taxes. So,
yes.
Counterproductive from a tax standpoint.
All the data we have from states that have pretty high taxes, including on e-cigarettes, shows that we still have a significant boon to the state coming in from the revenue, even when consumption is decreased. So that's why all of our data shows that it is a public health win as well as a economic benefit.
But when we talk about that it's disproportionately unfair for minors and those in poverty to assess fines, it's also will be the other side saying that this also negatively affects and is disproportionately unfair to lower income individuals, right?
Yeah, I'm sorry if I interrupted you before. Is that the question that I should answer?
I'm just saying this group is very much appreciated. Former Representative Harold Wright had a clean air bill that almost barely after 12 years got done. So even though these are all, I mean, they're all great things. I mean, I think the $30 versus 3 year for the business license is something that, even though I think the big swingers will come out and fight, that's not a hard sell and providing more revenue. So I think that is a great bill if you have somebody pushing that this year that could actually get done with the amount of push. What I'm trying to get across is there's so much headwind on the topic that if you want to get something done against childhood smoking or vaping, it has to be an interim thing. It has to be a January thing, a February thing. It can't be show up the day that a bill pops up on the floor to fight.
Yeah, absolutely. I think you're probably alluding to some of the defense we've had to play as well. So needless to say, some of those bills weren't really started early in the process either. So of course we're going to react to those as well.
Which I agree, and how some things make it to the floor. Pretty amazing.
Sure.
Can I interject something on that relates to what he just said, talking about the tax revenue side of it? From if you're decreasing consumption, you're decreasing taxes. Is there any kind of data out there that, for instance, like an insurance breakdown? So, for instance, if you have someone or a group of individuals with all of these long-term medical costs related to smoking that may be paying for out of healthcare authority funds because they're a Medicaid person, do we have any kind of numbers that show how much money we could save to specifically state-funded insurance programs for people who aren't smoking versus people who are smoking?
That's a great question. I don't have that data. I don't know if TSET does. And we can work on that too.
Yeah, I'll look and see if I can find that number. I think that number exists, but I don't have it with me today. But I'll do some looking and see what I can find.
Because in my mind, that could potentially offset the revenue decrease from taxation and, people using less, if they're not using it as much, they're not paying as much. But I think also there's going to be that savings component possibly to the Medicaid system if we don't have those health problems to pay for.
Yes, and thank you so much for making that point. I did have it in my notes, and I apologize for missing it. But of course, when we do decrease consumption, there is the additional savings to the state in terms of those costs on tobacco-related health expenses that we don't have to pay.
And it would be great to be able to show that during session.
Are you is that 264 the cost savings from, or that's what's currently being spent on? Okay. Thank you. And I think you could also factor in lost time from work and those kind of issues as well.
So do we have anyone running any legislation for increased licensure at the
There's a bill that was introduced in 2021 that is still alive by Representative Marcus McIntyre, HB 2128, related to licensure. We also, though, I would say, are looking to really look at the PUP issue because, as you've mentioned, Representative Marty, it's a much narrower scope in the way our laws are written and would be a much briefer piece of legislation than our very comprehensive licensure bill. So we don't currently have a bill looking at PUP, but hoping to work with a number of parties, included those of us up here today, to talk about that issue in particular before addressing licensure on the whole. And we do have a tax bill that is still alive from 2021 as well, which was, I can't remember the number off the top of my head. 2754 maybe? I don't know. I'll have to go check what it was.
Are you talking about on the e-cigs?
That was authored by Representative Randleman. And then the final piece of legislation that we've been working on that is still alive from 2021 relates to the preemption issue that Elizabeth mentioned, and that's HB 1893, authored by Representative Boatman.
Well, I don't have any more questions. I just want to thank you for coming and thank
you
everyone
so
for
much.
presenting today. I was waiting for the marble man or a camel to walk in and present to us, but I guess that's not going to happen today. So, do you have anything else?
I don't have any other questions or comments. And once again, I thank all of you guys for coming. This is a very, as a healthcare provider, this is a very important topic to me because in my practice, I see a lot of tobacco-related illnesses that disabling illnesses in a lot of cases, and I think it's something that always is going to need to be worked on and awareness be made. So I appreciate every one of you guys for being here and your hard work.
All right, we will be back. We will adjourn until 1 for lunch. We'll be back for opioids this afternoon. So. alcohol, tobacco, and controlled dangerous substances. This afternoon from 1 to 2:30, we have Representative Talley, Burns, and Stinson presenting on opioids. Apparently there's a handout, so make sure everyone gets one. Show's yours.
Okay. Okay. Thank you all for coming. This has been a very eye-opening experience. Hearing from people across the United States who suffer unbelievably. And we've made some knee-jerk reactions as Congress people across the United States. We don't want people to die from opioid problems. But we have also punished many people who need opioids. And so when a constituent of mine came to me and said, this is very important, Representative Burns and Representative Stinson said, yeah, they're hearing about it too. And then as we've looked into this, there are legislators who use opioids every day and need it to live life. And so we're very glad to bring this to you. Representative Burns, do you have anything you want to say in the opening? I'm good. Okay. And Representative Stinson's not here. We'll ask him later. But I want to introduce a friend of mine that's been a friend since she was a kid in high school. And she said this is important. So she has really worked hard at putting this together with a lot of friends. And hold on just a second, Tamara. Representative Stinson, would you like to say anything for an introduction? No. Okay. Tamara?
The first thing I want to say.
Wait. Go up to the mic and introduce yourself and say your name. And
if you'd prefer, you can also sit and grab that microphone and drag it over to you if you'd rather sit. Either way.
It's probably better anyway for
Okay.
me. Is it on? Are we? Yes, it's on. Yep, you're on. You're not. Okay. First thing I wanted to say was thank you. As he said, my name's Tamara Stewart. I'm with the P3 Alliance. I am the pain patient that ended up being left kind of in the dark whenever the knee-jerk reactions happened. All of the supply-sided interventions trying to limit opioid prescriptions, of course they were done with absolute, best of intentions. It seemed logical at the time. And then it trickled down to kind of the wrong side, and it was ending up harming the patients that did take them every day and not changing anything on the outsides. In fact, all we had were increased overdoses. So we started really digging into it and trying to find solutions, ideas, and through that I have met an incredible group of people. Specifically, we have Dr. Beth Darnell, Zach Rhodes, the legislators in this room, colleague Julia Heath from Texas, Tom Plotz. We have such an incredible number. There's 800 here in Oklahoma alone that I have connected with specifically. There's 8,000 just in the United States, just in our little organization. That's how big of a deal it's become in just the last few years. So, thank you again.
who's our first presenter? And introduce them, please.
All right. First up is Beth Darnell from Stanford University. Do you want me to read the bio? Or?
Greetings. Can everyone hear me okay?
Yes.
If I share my screen, can everyone see it? Sorry, I'm not getting any feedback, so I can't.
Yes.
If I share my screen, let me try this one more time.
Yes, ma'am.
Sorry. Sorry, I'm trying to share my screen, but it doesn't seem to be working. Actions. I apologize. I'm not having luck sharing my screen or figuring out how to share my screen.
It worked at first.
It worked at first.
It did. Okay, shoot. Let's see if I can.
I'm no help.
Let me try. Let me try one more time. Okay. Let's see.
Yeah, we have some notes for most of us. Yes.
You do.
Yes.
Can you see this now when I'm sharing?
No.
You can't see that.
No.
Okay, I apologize. Let me try just one more thing. Control E. Yeah, okay. I'm sorry. I just cannot figure out how to share this content.
Okay, we can share it.
Wait a minute. I apologize. Did that do it right there? Can you see that?
Yes, ma'am.
Okay, perfect. All right. I'm going to go quickly. First of all, I want to thank Representative Talley and also Tamara Stewart for organizing this very important event. This is a topic that's very near and dear to my heart. It is about protecting patients with chronic pain and ultimately ensuring health and safety in opioid prescribing and deprescribing. You can see here my affiliations at Stanford University. These are the organizations that fund my research. I'm very focused on both pain reduction and also patient health and safety within the context of voluntary opioid reduction. As you know, pain is a massive problem in the United States. Up to 1 in 3 individuals is living with ongoing pain of some type, and this is of tremendous consequence to the individual, to families, and it also has tremendous economic consequence as well. Now, as recently as 2015, 2016, we saw that up to 3.4% of the U.S. population was taking daily prescription opioids to manage chronic pain. This was up to 11 million individuals. And so this was a substantial fraction of the population who really got caught in the crosshairs when the 2016 CDC opioid prescribing guidelines came into effect, and there was a focus on reducing opioid prescriptions. So even though the 2016 CDC guidelines were really focused on new starts, what began happening was people taking dose thresholds and wanting to reduce people who had been taking opioids for years or even decades. And what we see is that reducing opioid doses is not as simple as reducing any other medication, such as an antibiotic. And we see that we are exposing vulnerable patients to new health risks by reducing opioid prescriptions when opioids are not reduced the right way. We saw tremendous fallout between 2016 and 2019, increased health problems, suicidal ideation, suicide, overdose deaths as a consequence of opioid reductions themselves. There was a public outcry over these 3 years, and ultimately there were clarifications that were issued by the FDA and also the CDC that were intended to focus on improving health and safety for patients with chronic pain when opioids were reduced, to never reduce quickly and to assure patient-centered protections. In fact, there has been a burgeoning of research in the past 5 years now that have demonstrated these new health risks that we have exposed patients to in an effort to reduce opioid doses and keep them safe. So while we can recognize, as Tamara mentioned, that this was a good faith effort intended to help patients, there has been massive fallout. We see here just a fraction of the literature that focuses on when opioids are tapered, we see that patients are exposed to morbidity, mortality, suicidal ideation, suicides, mental health crises. This is what we call iatrogenic consequences because these new health risks are actually caused by the medical intervention itself. This was a recent study published in JAMA that focused on a large patient population, over 100,000 patients studied, that showed that when opioids were tapered, they were exposed to mental health crises, also suicidal ideation and other health risks. This is a critical issue. These are our most vulnerable patients living with complex medical conditions that deserve protections. So what have we been getting wrong? Well, in the effort to deprescribe, we have failed to implement patient-centered care and take into account the needs of the individuals. We have applied one-size-fits-all approaches that necessarily are exposing a fraction of our patients to new harms. So we need flexible policies that attend to the individual needs of the patient and recognize that opioid reduction is not right for everybody. Now, what we see when opioids are tapered the wrong way, either when opioids are tapered too aggressively or when there's a forced tapering situation, we see that we're exposing patients to a whole host of new problems. And some of these have been demonstrated in the literature. What we need are policies and clinical practices that focus on treating the person with pain and do not reductively focus on the pill and reducing opioid doses. Now, this is a focus of my research that we have conducted in community-based settings. This was first published in JAMA Internal Medicine in 2018. We were the first study to describe patient-centered opioid reduction. And as I mentioned, this was done in community individuals with chronic pain, in which we invited them in a voluntary fashion to partner with us to help them achieve their lowest comfortable opioid dose over the course of 4 months. We did not talk about stopping their opioids. We were not focused on getting them to a specific dose threshold. We focused on the person and their needs and helping them to get to their lowest comfortable dose. We optimized patients' choice and their control in the opioid reduction process. So their participation was voluntary. They could pause their taper. They could stop their taper. We also allowed for opioid dose increases if those were needed. This is what constitutes patient-centered pain care within the context of opioid reduction. We enrolled 68 individuals, and I'm going to present some data for you that describes how patients did in our 4-month opioid tapering study. These are just some of the variables that we collected, and we are reporting data for the 51 people who remained in the study. Now, there's only one characteristic that described whether patients dropped out of the study or stayed in. Patients with higher levels of depressive symptoms self-selected out of an opioid taper. Therefore, these results do not generalize to patients with high levels of depressive symptoms. We believe that they need a higher level of protections and support. For these 51 patients, you can see they'd been on opioids for 6 years, and the average opioid daily dose was almost 300, so this was not a cherry-picked sample. When we implemented these voluntary patient-centered methods over the course of 4 months, we found that patients were able to reduce their opioid doses by about half without having increased distress or other symptoms. So that line in yellow illustrates that people were doing really well. Now, we can talk about averages all day, but we don't treat averages. We treat individual people. Each of these dots represents an individual person in our study. And what we found was that initial opioid dose did not predict taper response, meaning even people on high-dose opioids were able to reduce their opioid doses using our patient-centered methods without experiencing substantial increases in pain on average. So we're able to substantially reduce opioid dose without having increases in pain, and this is a critical metric, pain intensity, that is often overlooked and not accounted for. But look, this is where I want to focus all of our attention. I was just describing how patients do on average, but what I'm showing you here in these circles are patients who actually had increased pain with taper or patients who increased their dose over the 4 months. This is what we're missing in our policies. We're focusing too much on the average person, and we're neglecting to build into our policies flexibilities to attend to the needs of patients that are in these outlying conditions. There are some patients who do better on opioids, and there are some patients who have increased pain. We need flexible policies so that we can attend to their needs. We next followed patients 2 and 3 months later. And again, on average, patients were doing really well, continuing to reduce their opioid doses over time. But we need to focus on these patients who have special needs, and we need the flexible policies to attend to them. Now, I was honored to be invited to advise on the HHS opioid tapering guidance, which was published in 2019, and integrated into this HHS guidance were the methods of the study that I just presented to you. We have now extended our opioid tapering research and these patient-centered methods into a 4-state national opioid reduction study. This is called the Empower study. I am the principal investigator, and it is funded by the Patient-Centered Outcomes Research Institute. We have embedded our patient-centered opioid reduction methods into clinical care in about 15 pain and primary care clinics in various states in the United States. And we are focusing on patient preferences. We have integrated in voluntary methods, and our primary outcomes are both pain and opioid dose reductions. Patients informed the design of our study. When patients come into the Empower study, everyone partners with their physician to implement a voluntary opioid reduction program over the course of 1 year. And then we provide them with various behavioral supports to help them better manage pain and distress and any other symptoms that they're having over the course of the study. These are the sites where we are enrolling people in the Empower study, and we work with physicians and train them to help work with patients in a patient-centered manner so that the patient need and the patient voice are accounted for. Because Empower is a voluntary study, we must create a safe and caring environment so that patients want to stay and remain in Empower. We do this by accounting for the patient choice and their readiness to taper. So we follow patients on a weekly basis to get their feedback, to get their opinions, and we are collecting the evidence to support what will become best practices for opioid tapering in the United States. And we believe that this cannot be done without integrating the patient voice and choice very carefully into the methods. One of the ways in which we keep patients safe is we monitor them very closely with e-surveys that we deploy to them weekly. We monitor for withdrawal symptoms, for mood changes, for any problems that they may be having, and we have automated systems to be able to address any problems in rapid fashion. And in summary, I just want to say that what we need are application of patient-centered principles. We recognize that opioid tapering is not right for everybody. We recognize that opioid tapering can increase health risks if it's not implemented the right way. We need to monitor patients very closely during tapering, and the patient response to tapering should inform inform their next steps. We desperately need policies that reflect patient variability and protect prescribing for patients who need opioids to better manage pain and medical comorbidity. I just want to say thank you for allowing me to speak, and I offer all of my methods and all of our supports funded by the Patient-Centered Outcomes Research Institute at no charge to the state of Oklahoma, should that be desired. Thank you.
Wow. Are you passionate or what?
I'm sorry?
I said you're very passionate. I love it.
Oh, yes. This is my world and my life. I'm here to serve and be pleased to help Oklahoma in any way possible.
Okay. Questions? We're already over, but let's take a couple of questions right now, if anybody has any for Beth. What were you thinking? You got to walk up to the mic. Introduce yourself, please.
My name is Mike Andrews. I'm a chronic pain patient and a friend of a chronic pain patient who had her opioids decreased to 90 MME and daily, and had her anti-anxiety medications forcibly terminated. How do you feel about that? Thank you.
Yeah. Thank you very much for the question. And I'm really saddened to hear that this patient experienced forced opioid tapering. This is not part of the Empower methods. What we need are voluntary methods and systems to support patients who wish to decrease opioid doses. And we also need the flexibility to preserve opioid prescribing for that fraction of patients who do benefit from opioids insofar as supporting pain reduction and also increases in function. So there are a fraction of patients who really need medications to help them live better. And again, I'm sorry to hear that that your friend was caught in this in the crosshairs of this situation.
We need to move on, but you are more than welcome to stay on. But thank you so much for your information and your presentation. Tamara, who's next?
Next is going to be joining us is Zach Rhodes.
Zach, would you introduce yourself, please, and what you do?
Yeah, you can hear me now, I suppose. Sir. Okay, good afternoon. I'm Zach Rhodes. I'm a consultant for children and families in Vermont, and I also work with psychologist Dr. Stanton Peel in an online addiction coaching program called the Life Process Program. Dr. Peel and I wrote a book together called Outgrowing Addiction, which demonstrates our addiction and drug policy research.
Huh. What do you have to present to us today?
I want to echo a lot of what Dr. Darnell said, but I want to do it in a more focusing on more fundamentally what addiction is, because I presume that's one major concern that comes up when thinking about policy implications. My research became focused on addiction psychology and drug policy when I had a destructive relationship with heroin when I was in my 20s. And I was lucky enough to bounce back from it without treatment. And I don't say that because I'm cavalier about addiction or something like that. Actually, I thought I was an anomaly. But the deeper that I got into addiction research, the more firmly I understood that my story of, let's call it natural recovery, is actually the norm and not the exception. And that's information that I thought is going to be useful today. I want to discuss the implications of my research in making policy decisions related to opioids and regulations on prescribing. To save some time, I've shared a document for the record, complete with citations and links to the research that I'll reference. There are two fundamental truths about addiction that are clear, but which most people, including policymakers, ignore. These truths have major implications for drug policy, though. One is that most people who use drugs, even so-called hard drugs like opioids, including heroin, don't become addicted to them. And two, some people do become addicted, clearly. But of those people, most of them discontinue chaotic drug use over time without treatment. So again, taken together, these two fundamental truths have major policy implications, certainly implications for those who want and need access to opioids for pain relief. I'm going to echo Dr. Darnell here. If there's only one message that you take away from my testimony that influences the way that you think about drug policy, I hope that that one message is don't focus on drugs, focus on people. Here's why. Let me visit those two fundamental truths in more detail. Most people who take drugs, and let's focus on opioids, don't become addicted. They take them a few times and discontinue use, or they use them with some consistency but without impairment and distress, i.e. addiction, in their lives. They pay their bills, they work, they take care of their families, they're productive citizens, and they have a balanced life. And you might say that goes against everything I believe about drugs. And I don't fault you if that's an intuition, because our culture is awash in stories about drugs, that they're inherently addictive, and that most people who take drugs, certainly opioids, become addicted to them. But the data is overwhelming, including data from the United Nations Office on Drugs and Crime, that most people who use drugs don't become addicted. My colleague, Dr. Stanton Peele, does an exercise with audiences that he speaks to, and he asks, how many people in this room have ever taken a narcotic painkiller? And most people will raise their hands. Most adults have taken painkillers at some point, whether it's for dental procedures or otherwise. And then he'll ask, well, how many of you are addicted to those drugs? And rarely do any hands go up. So a room full of people, most of whom have taken opioids, and virtually none who have become addicted to them. Then Dr. Peele will ask, well, why didn't you become addicted? And people will say things like, well, I stopped taking them when the prescription ran out, or I was no longer in pain, so I stopped taking them, or they made me feel great, but taking more of them would have gotten in the way of my responsibilities or other involvements that I enjoy. In other words, drugs by themselves aren't addictive. People become addicted when the relationship with the drug disrupts life balance. This ties into what I'm calling fundamental truth number 2, that most people who become addicted get beyond that addiction over time, or they outgrow their addiction, as the title of my book suggests. There are massive government surveys done every 4 years called NESARC, or the National Epidemiologic Survey on Alcohol and Related Conditions. Over 40,000 people participate in each 4-year wave of these surveys. And the surveys reliably show that most people who become addicted to illicit drugs cease addiction by age 30, and they usually quit treatment. They usually quit without treatment or support groups. Then longitudinal studies show that even after 30 years of age, people continue to quit through their lifespans. Over 90% of alcohol and drug addicted people quit, again, without treatment or support groups. So how is that possible? Well, Dr. Gene Heyman did the work for us. He conducted a meta-analysis that showed why people quit, the reasons why people kick their worst habits. They mirror the results of my colleague's little audience polling experiment in greater detail, though. People quit addictions because they have attractive alternatives in life that don't drive with chaotic drug use. So meaningful work, family, relationships, strong community, housing, social factors. In other words, people stop relying on drugs for fulfillment when they have attractive alternatives. So the key question is, what about people who do become addicted, or people who can't seem to kick their habits? It follows that if, per government studies and Dr. Gene Heyman, attractive alternatives to addiction lead to quitting addiction, then a lack of attractive alternatives perpetuates addiction. I'll just say again, in order to help those in the most dire need of help, we need to shift our focus away from drugs and start focusing on people and their life circumstances. Put a little bit differently, addiction is not an equal opportunity destroyer. And who's most likely to die from drug fatalities? I'll quote West Virginia's Health Commissioner, Dr. Rahul Gupta, who says, quote, If you're male between the ages of 35 to 54 with less than a high school education, if you're single and you've worked in a blue collar industry, then you pretty much are a very, very high risk of overdosing. So what does this have to do with pain patients and their safety and rights and quality of life? Well, my research indicates that drug-focused policies are missing the mark at best, but have detrimental consequences at worst, as Dr. Donnell showed beautifully. In the last decade, we as a nation have responded to drug fatalities by reducing numbers of prescriptions. The idea being that if we eliminate the drug, we eliminate the problems. And it doesn't work that way. We know solutions to systems problems don't work that way. They're not that easy. So as we pushed a nationwide 60% reduction in opioid prescriptions, we've also seen 1.5 times the drug-related fatalities. Fewer prescriptions and more death. Interestingly, in Oklahoma, I've seen, this is just a cursory look at the data from Oklahoma. From 2013 to 2018, your trend went the opposite way. So fairly liberal prescribing, at least relative to other states, and opioid-related fatalities decreased from 475 in 2013 to 191 in 2018. So in Oklahoma, between 2013 and 2018, rather than less prescribing and more death, there's been somewhat liberal prescribing. I don't know if that's the way to say it, but fewer fatalities. And it's my understanding that lawmakers in the past 3 years or so have felt pressured to conform to some national strategies and to diminish access in some respect to prescription narcotics. But the less prescribing and more death trend, I'm certain, can't be the direction that Oklahoma wants to go. People are going to use opioids for various reasons. And when we take away safe supplies of drugs, people won't stop using opioids. They'll use the less safe supply of opioids available to them, even if that means procuring drugs from an underground market. Some people continue to use drugs even when it causes impairment and distress in their lives because they lack attractive alternatives to the experience the drugs give them. But many people use drugs to enhance their lives rather than to detract from it. And I know you're going to hear from a group of people who do exactly that, a group of people who take pain medications for pain, or they wish to take pain medication for pain if only they had access. Some pain patients are pressured or forced to taper from narcotics, even though the narcotics are a pillar of their pain management strategy. You might imagine that if you dealt with chronic pain and painkillers were a part of the regimen that made life bearable, and those were taken away, that you would do what you needed to do to replace those legally prescribed and safe medications with some other form of relief. And you might imagine that this desperation, caused by no fault of their own, is part of what's causing fatalities that you've seen in Oklahoma in 2021. I'm now looking at a line from a state investigative report, July 29th, 2021, and says state investigators have found nearly 24 fatal overdoses over the past 15 months tied to fake oxycodone. Right. Let's go, folks. I implore you, ladies and gentlemen of this committee, to keep in mind that drugs by themselves are not an enemy, they're a tool. So the task at hand is to keep people safe. That doesn't mean taking away the things that relieve their pain, but focusing on why people have pain.
Right.
And allowing them all of the available options to treat it and to better their lives. So concerns about addiction and drug death are reasonable, of course, but we need to let those concerns be constructive by considering data on addiction, recovery from addiction, and the real underlying reasons for addiction and fatalities. So I hope that you'll all join me in focusing not on drugs, but on human beings, and that any drug policy decisions that are made align with the fundamental truths that I've offered today. Thank you, Representative Talley, and all on the committee for allowing me time to speak. I know I'm pushing my allotted time, but I'm happy to answer any questions that any of you have. Thank you.
Thank you. Thank you for your presentation. We're going to wait till the end. Can you hang around for a few minutes? Thank you.
Fair enough.
Let's do the panel.
Hi, Cindy. It's good to see you.
Oh. okay, yeah.
Cindy, did you have a question?
Yes, sir. Right. Hey, you're the boss. We'll do it. Oh, yes. We do have another study in this room at 2:30, so that's why we're a little bit pressed for time.
We originally had more patients coming for the panel today, but we do have these two gentlemen here today. Got Dr. Lawrence Pasternak and Daniel Baird. Did I say it right? Baird. I knew I was going to get it wrong. I apologize. Both of them are just going to speak to something, and the only thing I want to make sure we understand that is brought forward here today, all the studies you all see, that opioids do not work and what is and is not. Focus on low back, knee, osteoarthritis pain. That is 20% of the real world. So now we're going to introduce you to the 80% of what we really deal with, because that is very unrepresentative. That mild pain is not where we are today. So,
Go ahead, introduce yourself and talk to me.
My name is Lawrence Pasternak. I'm a professor at Oklahoma State University, professor of philosophy. I'm also the director of religious studies. Of course, I'm here just as a private citizen. I have scoliosis, and probably a lot of you know what that is. Those of you who don't, it's a curvature in the spine. I basically inherited it from my family. Both my parents had scoliosis or have scoliosis. And in my case, it's cervical and upper thoracic, so in my neck and upper back. And this causes pain ranging from the back left side of my head, through my neck, through my upper left back, across my left rib cage, and down my left arm due to impingements of nerves. When I was in my 30s, early 30s, I started to first notice it. I knew that I had scoliosis from my teenage years onwards, but I was fine through my 20s, and in my early 30s, I just started to notice episodic pain, lifting heavy things and leaning too far on my left and so forth. And that was okay. It just wasn't that much of an impact on my life, but it got worse. And I was in a car accident in 2004, and that basically impact on me, I think, exacerbated the effects of that scoliosis, and even though I was offered some opioid medication after that, I resisted it for a few years, and eventually just the pain got bad enough that my doctor encouraged me to go into pain management, and I was prescribed, in 2007, I was prescribed time-release tramadol. Found it to be very effective, occasional breakthrough opioid in addition to that. But I found the tramadol to be very effective for quite a few years. The pain started to get worse, however, when I got busy with work. So because of where the scoliosis is, leaning forward, raising my arms, doing things like this, typing, basically exacerbated the pain, even eating. Bad enough so that I would sometimes have to, in the middle of a family dinner, lay down. I might have to spend 5 or 10 minutes laying down on the sofa before returning to the dinner table, or just leave the dinner table even though I wasn't finished eating because I was in so much pain. And so because that came in the midst of my working on a book, starting around 2011, 2012, my doctor switched me, or added, in addition to the tramadol, OxyContin. And so I found that to be very helpful, and from 2012 through 2014, completed my book. And when I finished my book in 2014, I dosed out of the OxyContin, and basically I just titrated down over about 3 weeks, and it didn't seem at all problematic to me to simply just cease using it. So the years went on beyond 2014, just again using time-release tramadol and, as needed, some breakthrough opioids. And then as the pain started to get worse again in my early 50s, I'm 54 by the way, I decided to try using OxyContin again, but my doctor wouldn't allow me to add it on in addition to the tramadol now because of the new pressures they were put onto pain management, where it would be a red flag, so the doctor thought, to have me on 2 different time-release medicines. So my option basically then was to stick with the tramadol, which I wasn't finding to be as effective, or use a much higher dose of OxyContin than what I had previously used and what I felt that I needed. So basically replacing the entire dose of the tramadol and a small dose of OxyContin with a much higher dose of OxyContin. I tried it for a little while, and I just went back to the tramadol, and basically my thought is, when my pain gets worse, when I take on a heavier project, when I need to increase an opioid dose, I'll do so. But frankly, I think the most effective scenario for me would have been, as I had when I was writing my last book, the time-release tramadol with the lowest dose of OxyContin available, but I can't have that anymore. One other thing that basically the increased scrutiny from the Bureau of Narcotics and from the Attorney General and so forth, one further consequence of that increased scrutiny on pain management is that they discontinued all benzodiazepines. And so I had for many years, just due to my own anxieties or due to pain, used on occasion a benzodiazepine to help me sleep. I found that basically about 30 pills lasted me a year to a year and a half. I would use about a quarter of a pill at a time. It was very effective just in that very low dose, and it allowed me to sleep when I was stressed. It allowed me to sleep when my pain was worse, and that was taken away, again, for policy reasons. And that was, I think, in late 2017, if I recall, and I had quite a few months after that where they tried all these other sleep aids, over-the-counter sleep aids. Unisom, I tell you, Unisom was awful. It just like I was asleep for the next day. And so eventually I found some alternatives, non-prescription alternatives, but those took quite a few months, the better part of a year, to eventually figure out. And very, very low doses of an opioid, very, very low doses of a benzodiazepine doesn't strike me as something that should be restricted, shouldn't be prohibited, and yet nevertheless, circumstantially, even though not in law, circumstantially, basically there's almost no doctor out there that would allow the concomitant prescribing of even very low-dose benzodiazepines with very low-dose opioids. So I'd say those are the 2 issues that I now face, that I hope to write another book. I have actually I have one under contract, but I'm waiting for better pain management in order for me to move on to the next book. I guess
okay.
That's it.
Thank you.
Yeah. Questions?
I wanted to, if I might, my name's Julia Heath. I'm also part of the P3 Alliance. I'm also a former physician assistant who worked in pain management. And there's something that I always want to make sure that people who don't work in medicine understand, and that is that prescribing opioids with benzodiazepines or with antidepressants or anything like that, there's nothing illegal about that. There's not even anything disastrous about that. And so where the confusion has come in for someone to think that, or for even physicians to think that they can't do that anymore, even though they know it's not illegal, even though they know they've done it in the past, there's some confusion there on why different classes of medicine now, which used to be prescribed together all the time, can't be. So I wanted to make sure y'all were aware that there's not a legality in medicine that would prevent a doctor from prescribing those kinds of medicines together. Just wanted to make sure y'all knew that.
Thank you.
All right, Dan, come on.
Good afternoon. My name is Daniel Byard. I'm a business analyst. I've got a Master's of Science in Administration. Today I'm speaking to you as both a patient and a caregiver. I myself was hit by an uninsured drunk driver about 12 years ago. I had severe damage to my knee, my neck, my back, as well as a concussion. I'd suffered migraines. I was diagnosed at age 8, so I've actually got a much higher pain tolerance than normal. just because I've had it most of my life. And after my accident, I went as long as possible, like Dr. Pasternak did, without being placed on opioids. Not unfortunately, opioids helped me live my life. I coach my daughter's soccer team. I go to work every day. I don't take more than I'm prescribed. I've never sold them. I've never bought them off the street. I've actually got a much better tolerance and a lower need for them than my wife does. That's the main thing I'm here to speak about. She was hit by an uninsured drunk driver 16 years ago. She's had 19 surgeries, 5 of which have been on her neck. We actually see the neurosurgeon on Wednesday at 10:30 to discuss neck surgery number 6. She'll be 42 years old in about 17 days. Opioids helped her function. Once she got on a stable dose with a good pain management doctor, like Dr. Darnell stated earlier, she was immediately cut in half. That sent her into a seizure at our daughter's 3rd birthday party. Being there with her and catching her from falling on the floor, it was devastating for me. The noises that her body made, I got clinical PTSD from this. When she coughs or clears her throat, it's similar to the noise that she made when she suffered the seizure. I go into anxiety from that. Unfortunately, with the forced tapering, being cut in half and then forcefully tapered further down from that amount, she no longer works. She was a physical therapy assistant. We used to go to date night Friday night, daughter's soccer game Saturday, church on Sunday. Everything was great. She had about 2 to 3 really bad pain days a month when she was on a dose of medication that was appropriate for her pain level. Now we're lucky to have 2 to 3 decent days per month. So my wife is basically living Oklahoma proof of what Dr. Darnell previously presented earlier. Another unintended consequence of all the policies is the pain contract. If you're on a pain contract, everybody looks at you like you have a scarlet letter. They don't want to treat you. They're afraid to prescribe you what they would anybody else simply because you have a pain management contract. After my wife's seizure, she was taken by ambulance to the emergency room. 5 different physicians all agreed that it was the lack of opioids that caused this seizure. Not one of them would give them to her. They said, sorry, she's in pain management. And I'm like, I will deal with that later. Please treat my wife. And we had a similar instance about a month ago. My wife went 81 hours with no sleep due to uncontrolled pain. That led to a really bad anxiety attack. She was curled up in the fetal position, crying uncontrollably, could not even verbally respond to myself. I called 911. We get her to the hospital in an ambulance, and they see she's in pain management. They know she has a history of neck issues. They gave her some Benadryl and said, follow up with your pain management doctor, follow up with your surgeon, follow up with your PCP. So these policies are preventing people from getting other treatment. Since this forced taper, my wife went from being in pain to having depression, anxiety, insomnia, tachycardia, hypertension, and now she's basically got wasting disease. She's in too much pain to eat. I'm literally watching my wife whittle away. She lost 11 pounds in the course of about 6 weeks. She hurts too much to eat, lack of sleep. She gets dehydrated. She sleeps when she can. She obviously gets to the point where she's just exhausted, and she may sleep 16 hours straight. That's the only way she doesn't hurt is when she can finally get herself to sleep. There's nights I've got to stay up all night long with her to comfort her, to just keep her out of there. Going into that place from the pain, wherever it drives her mind from lack of sleep and, the fatigue from the pain. And then once she's finally settled, I've still got to get up. I've got to get myself dressed. I've got to get my daughter ready for school. I take her there. I come back, make sure my wife's comfortable, keep drinks or whatever close to her bed, adjust the bed, adjust the pillows, get her the heating pad, get her the ice packs, get her the E-stim, get her the infrared mat, all these different things that we have to try to reduce her pain because her pain medication has been reduced. And it's heartbreaking. She's been diagnosed as palliative, which is a diagnosis that is specific to people that have life-limiting illness. Unfortunately, she has non-cancerous pain, and she is not terminal. Therefore, she can't even get treatment under palliative care, which has an exemption to the CDC guidelines. She does see pain management. She takes her medication as prescribed. It's not really helpful for her. She's a lot smaller than I am, but her pain level and her need for medication is higher than mine is. And everybody is different. Like the previous presenters have said, you need to treat the patient, not a policy. So we just keep on going on like that. This uncontrolled pain has had a negative impact on every single relationship she has in her life. She can't go to birthday dinners. She can't go to church. She's losing some of her faith in God. Thankfully, we've had the discussion that she will not commit suicide, that she will come to me if she has suicidal thoughts again from the pain, and I will do my best to get her the help that she needs if we can get it. That's my worry, is she will get to that point again, and we won't be able to get the proper treatment for her. So thankfully, we have had that discussion, and it's not a huge concern of mine, and she still does have some faith in God. Otherwise, I think she probably would have already ended her life. And the hard part is she feels like a burden to her family, to her friends, to society in general. And, you know, I want my wife back. My wife wants her quality of life back. My daughter deserves her mother back that she once had before she was forcibly tapered off her pain medication. And the hardest part is there is a solution to help my wife and give her her life back. But because of certain policies that are in place, she can't get that.
I'm so sorry.
Thank you, sir.
Thank you.
You're welcome.
For sharing.
Does anybody have any questions?
I'm sorry, we have to keep moving, but thank you for coming here.
I'm going to introduce Sheriff Tim Turner, and I believe he's with us today on Beats, I think is what we're doing here. He's the sheriff of Haskell County, and so if you would go ahead and share with us what you have in mind today for us. Thank you.
Can you guys hear me?
Yes, sir.
First and foremost, I want to thank Representative Talley for putting this together today. I think my approach is going to be a little different than what you guys have heard today. First and foremost, my background is I spent 11 years at a drug task force where I supervised that drug task force for 7 of those 11 years, and then I was at DEA for 6.5 of those years. So my background before being sheriff comes in the enforcement side of this business, of what we're seeing. So I'd like to talk about a little bit of what we've seen and what we have. So in 2018, we have policy put in place, and since then we have seen a reduction in overdose deaths from pharmaceutical overdoses. We have seen an increase in overdose deaths from substances such as heroin, fentanyl, of the illegal substances that are plaguing Oklahoma that we hear about daily. I was asked prior to this today about what we see demographically in our area, and I can speak to what we see demographically in the rural areas. Is we still see that 18 to 35, 18 to 40 years of age substance abuse addicts. And when I want to talk about addicts, what I've learned, and first and foremost, 10 to 12 years ago, you'd have heard me say, hey, jail, incarceration, that's what we have to do. But what we have to first identify with our substance abuse addicts that we see is there's a mental health issue as well. So we have a mental health issue that underlies with those addicts. And since the passing of State Question 780, especially in the rural areas, we have seen an increase of reoffenders with drug abuse. And we can talk about opioids, we can talk about methamphetamine, we can talk about all of that nature. And the reason that we're seeing the increase is because we have no way to get those addicts and the substance abuse users who have become addicts. We have no way to get them the treatment that they need, other than we try. We go to the methadone, or we go to the Suboxone, things like that, which creates another problem within itself. In our area, we don't see a high issue of folks who are actually using a legit purpose, opioids with a legit purpose, being those folks that we encounter on a daily basis. What we see is we see those folks in that 18 to mid 40-year-old range who are substance abuse users and are using those substances to get high and not actually treat pain. But I will say that we have seen a reduction in the pharmaceutical side of overdoses, but an influx in the actual counterfeit overdoses that we see. Right. And a lot of the times what we're seeing with our medical examination reports that come back from our overdoses is that we're seeing a cross between methamphetamine and fentanyl. And we talk about that, and we talk about the cross that's there. And through interviews that we have done, and again, I would say that I have done thousands of interviews of substance abuse users. Those, and most recently, the interviews that we're seeing is that these substance abuse users that wind up with, methamphetamine and fentanyl, what they're doing is they're using the methamphetamine, and then they have now learned that they can take fentanyl, or a counterfeit pill that we see, and that puts them back to sleep. That gives their anxiety back in reality, and it gives them the chance to sleep, where the methamphetamine's kept them up for days on end. So that is a huge issue that we're seeing. What we've also seen is a reduction, and I believe that the reduction is because prescriptions are harder to get for these addicts. What we're seeing is a reduction because the cost of a pill that we're seeing on the street of a pharmaceutical will range between $30, $35, $40 a pill, and the counterfeit pills are $10, $12, $14, $16. So I believe that's another increase in why we're seeing the rapid influx in the overdoses from fentanyl. Now back to our demographics that we have here. We are not seizing, nor have we seized a lot of actual pharmaceuticals. We see a lot more of the fentanyl coming in, which is a problem that we have from our southern border, that we all know that's flooding our market, and it's hitting our youth. And because they believe that it's okay, and because they believe that pharmaceuticals are legal, that's where we have those overdoses with that age group of folks. So to our study that we have in our local area, our folks that have severe pain issues and need the pain management, they're not the folks that we see inside of our facilities on a day-to-day basis. The folks that we're seeing is those folks who have addiction, which is, I believe, is a total difference than folks who actually need pharmaceuticals and prescriptions.
Thank you. I have a question for you. Why is it that it's so hard to get people help now? You said we can't get them help if they're overdose or overusing meth or fentanyl or something like that. Why is it hard to get them help?
State Question 780. It has taken those offenses from felonies to misdemeanors, and we cannot get those folks the treatment that they need. Used to, you would have teeth in the system where the court could order treatment, and I mean, we can agree or disagree, but I believe that forced treatment gives treatment. And we were told, as we all know, especially legislators in the room, that State Question 780 was going to produce State Question 781, which is going to put treatment inside of our facilities. And we have no treatment. Now, I will tell you, we are a little different in Haskell County. We do a substance abuse group treatment that is provided by our local health and wellness at free of cost, and we do that once a week for our inmates. We also do a domestic violence counseling once a week for our inmates, because I believe that any treatment we can get an inmate is better than the treatment that they're not receiving. So to answer that question, is 780 caused it? 781 is not putting direct monies back into our county facilities, which is we're seeing repeat offenders, and what we're seeing is a lot of those repeat offenders are now overdosing. I can tell you that last year alone in Haskell County, we had 12 overdoses that were Narcan saves because our deputies all carry Narcan. We're a firm believer of Narcan. But those folks are people who suffer from an illness, and addiction is an illness. And with the addiction illness, we also have to outline mental health, because mental health treatment in Oklahoma is horrible as well. Right. And we have to fix both of those issues.
Yes, sir, especially in rural counties.
Yes, sir.
Yes, sir. Thank you so much for your time. Any other questions? Okay, Tamara.
Next is going to be Dr. Stephen Draybeck. I'm going to speak to you a little bit about two separate issues, about how the how the death certificates are interpreted, but also he is a local pain management doctor and palliative care hospice. He can give us a really broad overview of everything that's happened on the provider side.
Thank you for allowing me to do this. I'm Steve Draybeck. I'm a family doctor for the last 35 years. 28 of those years I did family medicine, and 30 years ago I started doing hospice, which is my passion. At the time, there were no hospices in the Oklahoma City market. All of a sudden, we had two. And now we have plenty. But hospice is what taught me how to manage pain. When I first started, I thought it was odd. You know, the nurses, it's morphine for everything. Yeah, exactly. And it works, but the basic problem, because I'm going to blow some of you away, because I think the basic law is a good law. It put accountability onto physicians. It said, you've got to do this, and, you know, the problem that has emerged is the lack of education in the medical community. We don't get educated on how to treat pain. Chronic pain is not as needed doses of medication. You don't give people medicine for blood pressure. Say, take this when your blood pressure is high. Oh, and by the way, pain will increase it. It'll also make the heartbeat rather rapid too. So we're not trained to really deal with pain. And oddly enough, I remember the 1-hour lecture my class at OU had was by an orthopedic surgeon, who I'm sure was a very good orthopedic surgeon. He was the head of the department. His 1-hour lecture was, this is morphine, this is what it does, don't use it, people get addicted. Now, oddly enough, first question, a minute after that statement, somebody asked, is there any truth to what Grandma always said about the weather and pain? Immediately, absolutely not. Now, having said that, and that's the response most people have, but the analog is talking to me.
Oh, yeah.
The analog pain scale came along in the late 90s. Before that, it was mild, moderate, or severe.
Scoot over a little bit. There you go.
Is that better?
Yes, sir.
Okay. So the analog pain scale in the late 90s was used by the Hospice and Palliative Medicine Association to prove, lo and behold, Grandma was right. Barometric pressure does impact pain. So the lack of education and the lack of interest, after all those years of hospice, and I started doing chronic pain about 20 years ago. And it's not that hard. First thing is, PRN is out the door. It's not as needed. chronic pain is 24/7. So you've got to treat people around the clock. Tortoise and the hare. The tortoise wins every time because he's slow and he's persistent. So getting people to take their medication around the clock. My favorite words when people come back and say, you know what? When I take that medicine the way you told me to, I'm better. And I get to say, with a smile, I told you so. Now, sometimes it will take months for people to come to that realization. Now, the other part of it is I have chronic pain. I've learned more as a patient than I could in 10 careers as a doctor. That's why I'm passionate about what I do. Benzodiazepines, they've been around forever. They're helpful. They're indicated. They don't kill people. OxyContin has killed the same number of people as Smith & Wesson. The drug doesn't kill them. It's them eating it like Tic Tacs or taking a bottle at a time. Another job that I have for 18 years, I review life insurance claims. I've looked at more medical examiner reports than I would ever dream. And it's interesting because the overdoses really are pretty obvious. Because, you know, any amount of morphine above 0 is kind of what the medical examiners look at and call it toxicity, which is not always correct. If they're on chronic pain medications, they should have more than 0. The person that comes to my office and we do a drug screen and comes back with nothing, we worry about. Are they selling it or are they taking it? Are they getting the prescription for mom or dad who won't go? It's a lot of things. But 0 shouldn't be anybody that takes chronic pain meds. There's a study done a few years ago by a physician, and I think he's in California now, but he asked doctors who treated people with chronic pain to draw quantitative measuring how much. And so I participated in that, along with one of the other pain doctors at the time. And, you know, nothing really came of that because nobody really has an interest in pain management. What the new law did do is it gave doctors an excuse. When you're uncomfortable with something, you back away. Now, I've heard this so many times, it just angers me because, well, my doctor did this for a long time and now he can't. It's not that he can't, it's that he won't. They don't understand how to do it. They're uncomfortable. And the DEA doesn't put people in jail for doing the right thing. The State Medical Association doesn't punish doctors for doing the right thing. So there's a lot of things going on here. The other impact that this law has had is on the end of life and cancer patients. If you've got cancer and your oncologist has been treating you with whichever drug for the last 4 or 5 years, clearly you've done well. Chemotherapy's worked, radiation, maybe surgery. But then all of a sudden the oncologist says, oh, I can't do this anymore. Those referrals to me are easy. Bring them on, because it's justified if it's in the medical record. I've had people that show up as new patients. They come in, I look at them, I'm talking to them. When did you have that amputation? Because it was nowhere in the medical record. Sometimes the medical community looks at it, oh, they've got a prosthesis. They're fixed. It's not true. The biomechanics Nobody can do better than the big guy. So original equipment is always good, whether it's a human body or an old muscle car. I have a whole bunch of crude analogies that I use, but the CDC guidelines, they're guidelines. They're not mandates. Nowhere does it say you have to get to 90 milligram equivalents. It also says cancer is excluded. End-of-life care is excluded. But now we're seeing hospice patients who are being told, we can't do anything else. We can't do any better for your pain. And that just makes my blood boil some days, because we can. If they're dying, it's easy. Whatever it takes. It's not there to sedate them. If you're in pain, you don't want to be sedated. You want to have a life. You want to be able to write books. You want to be able to continue to do what you do. For me, it was to practice medicine. I'm also a cancer survivor, so my passion, I guess God decided I needed a unique way to learn, but I've learned more as a patient than I could in 10 careers as a doctor. I did palliative medicine and hospice full time for about 3 years. Loved it. Didn't work out because the corporate mind is a different process. Life support, COVID. How many of those ventilators that were made emergently really got used or even were needed? If you get to a ventilator, it's not a good point. I was the guy that took people off life support. What it takes is a lot more time. We're being pushed in the medical world to do more in a shorter time frame to generate more money for about 5,000 levels of administrative burden. But that is the way it is. And I'm alive because of modern medicine. But we still have to take the time to do that.
Thank you.
So,
thank you very much. Yeah. Any questions? Thank you very much.
Thank you very much.
Okay. Yeah, I lost my help here. Oh, that's okay. We're going to skip ours for a minute.
That's what I was going to
Okay, because I want to make sure we get these last two in.
Absolutely.
Okay, so who's up?
Next, we have Dr. Vanilla Singh. She was nominated by President Trump for HHS and was I'm sorry if I don't remember a part of the pain management task force that from HHS that looked at all the solutions, all the gaps, all the issues. They laid out all the recommendations, and she's here today to give us a lot of the ideas and solutions that we can take back and turn into effective policy here in Oklahoma.
Thank you very much.
Good afternoon. Can everybody hear me okay?
Yes, ma'am.
Okay, great. Thank you so much for your time, Representative Talley. And I have Representative Burns, as well as Representative Stinson, Edmonds, and Dr. Drabek, as well as Sheriff Turner. And of course, Tamara Stewart, who's just been fabulous. It's really an honor to be here. I had the honor to serve in the prior administration as Chief Medical Officer and really helped lead the opioid crisis policy. And the biggest honor, though, was really chairing the HHS Pain Task Force, which came from congressional legislation. And so what I'm really here to tell you in the next 10 minutes is that everything that you've heard is true and even worse than what I certainly realized when I entered the administration in 2017. I'm a pain physician, anesthesiologist by training. I've been practicing for over 20 years. I've seen and taken care of the most complex patients, thousands in fact. And when the concerns about the opioid crisis came up, of course, that was something that caught everybody's attention when we heard about the overdose fatalities, the numbers, the affliction across the nation. But what was really stark was when I entered government from the private service where I practiced at Stanford, it was amazing that thousands and thousands of people had reached out sharing their really tragic stories of being forced off their opioid medicines. Even if they were on other multimodal treatments, these are people who have MS, Parkinson's, lupus, you name it. It is a multitude of diseases. These are folks who practice as CEOs or maybe homeless. And it is really everybody. I'm certain people in this room know folks like this. It's estimated to be between 50 and 100 million people. Congress was very specific and prescriptive in what they asked us to do, which is to have a sleuth of experts. We had mental health experts. We had patients. We had addiction folks, primary care. We also had the Department of Defense and the VA, who we were doing and leading the task force in conjunction with. We had the veteran service organizations, the largest one in the United States, as well as many other pain experts and oral surgeons, surgeons of various different types, and the CDC, the NIH, the FDA, and others. And so it was really about 29 people, and we looked at this broadly as Congress asked us to, from the state, county level in terms of guidelines to the national broad level. And they asked us to identify gaps and make recommendations, including review the CDC. And one sad, stark thing was, as the gentleman before noted, that the CDC guidelines, which were made really and intended to help guide primary care physicians, really had turned into a template of state laws and inappropriately being applied to situations which it never was intended to. The other thing was what was lost in this was really a dumbing down, algorithmic approach of assuming anybody who is on an opioid, which has medical indications, as opposed to cocaine or methamphetamines or heroin or illicit fentanyl. Medical opioids use has been around for a long time, and having a reset and thinking about it is very important. But to assume that people who are on it were taking it for the wrong reasons and were automatically assumed to be addicted with no sympathy was probably the worst thing we saw. We had 150 organizations that supported our draft report to Congress, but what was most interesting is when Human Rights Watch came to us, and I was surprised that the Human Rights Watch organization was following the task force, and they said that while the United States has always led in the effort of addressing pain and suffering, they were concerned that we were making regressive steps, and that's because we had somehow lost our empathy in terms of pain and suffering and had really reverted to a callous outlook. And I unfortunately have to say, after 2 hard years of spending on this particular piece of congressional legislation and executing on the task force with a really unbelievable report from so many different patients, I have to say I agree with them. And it has only become worse. I have been around the country sharing the numbers from the pandemic, which, as you all know, has led to financial stress, anxiety, panic, fear, as we've never seen before. People have been socially isolated. We're not living as human beings. And people who are already suffering from really debilitating pain that has already cost them their lives in terms of being able to take care of themselves or their family or having a dignified job are feeling this worse. And so no surprise, this is all being reflected in an increase in illicit drug use. Meaning prescriptions have gone down because of the great fear from the DEA and medical boards. All doctors know this. All doctors know this. Okay, anyone who is trying to even help treat their patients right now with opioids is sticking their neck out there and are asking for trouble, which is sad because folks with cancer, with debilitating complex neurologic diseases are amongst those it's hard to believe that we're in this country where, that's looked upon badly, but if someone has addiction, then they're given more empathy right now. But we're definitely at a time where we're seeing the opposite of things that should be happening. We're seeing money and resources go to folks who are perhaps not doing the best thing, and we're seeing a stark, callous approach to people who really need help and maybe have never broken a law. And we're on a regimen that was working well for them, and we're watching them being forced off, having no recourse and no doctor to take care of them. I came back into clinical practice at Stanford only to find a much worsened situation. The good news in all this is that the task force report really is a report intended for everybody. We have stakeholders who are lawmakers such as yourself, patients who can read this. It is intended for a scientist and a layperson to appreciate it. It is broad and deep, and it addresses not only all the various treatment modalities, but it talks about approaching things from an individualized, patient-centered approach. And what I mean by that is we are not robots, we're not mechanical cars. If I have a diagnosis and so does my friend, it's very possible we may not respond to the same treatment. Even if it was my brother or a twin sister, we would not necessarily respond to the same treatment because our genetics differ, our physiology differs, and our comorbidities, we may have other medical issues. And so medicine in that way is an art. And if we have the dumbing down algorithmic approach where we're not thinking, we lose the best type of medicine that this country has really established a long time ago. And I think chronic pain is symbolic of the type of things that the United States can highlight, which is an empathetic, compassionate approach in a complex, often situation where we can highlight advances in science, in innovation, but at the same time not ignore what real science is saying. And it doesn't mean that everybody should be on an opioid. It's about making risk-benefit analyses. It means that we have these smart monitoring systems, the PDMPs. We utilize all of that together and help to decide what's best for that particular patient using a multidisciplinary approach where it's a biopsychosocial approach. These are things that I know have certainly helped people, and I really thank the Oklahoma lawmakers and other honorable folks who are present to even make this a priority. The media advisory yesterday really warmed my heart. We need so many more people to open their eyes. We have been doing this across the nation, and I just really want to thank you for all your efforts.
You're welcome. Thank you so much for presenting today. Yes, TJ has a question. He's the boss.
So I appreciate you presenting today, of course. Your background's interesting to me. As a pharmacist, I own several pharmacies in the area, and obviously we're always the ones that are the bearer of bad news, unfortunately. But regardless of state legislation at this point, from everything that's been pushed down from the federal government, the lawsuits against Walgreens for $350 million for so they're not going to respond to anything, right? And then they go after McKesson and Cardinal as the wholesalers who cut off the pharmacies. I mean, typically by the 15th or 16th of the month, my pharmacy's out of most opioids, so I can't take care of patients even when we have to screen them. And the next guy sued by the DEA and locked up is the pharmacist, right? So it's just so everyone knows, the physicians are scared, and they're operating out of a position of saving their career and the future they built for themselves. But what can we do? And you've been close to the top of this thing, and again at a different administration. But what could we do possibly on a state level that's going to change anything with the federal government suing everybody involved up and down the chain?
Yeah, thank you so much for that question. I'm assuming it's for me. I want to just say that, first of all, thank you for recognizing. I know a lot of pharmacists are under a lot of stress. We had their input and, a lot of understanding of the challenges that they face, as do all the stakeholders. And I think it really begins with hearings such as this and that making the news, because the real thing is that there's a great fear and it doesn't capture the attention. What I think would make it also interesting is when these really draconian measures are put into place. Good people who have always followed the law are suddenly forced off maybe even minor low doses of opioids that they've been on for years. You find an interesting dynamic happen, which is either some of those folks contemplate suicide or they actually go to the black market where they think they're buying something and it's laced with fentanyl or its analogs. And, we've definitely highlighted that. That has been showcased in the Office of National Drug Control Policy, in the White House and other places. So the data is there. The DEA knows it as well. But I think when these things get highlighted, we see that not only is the compassion gone, not only are we not treating these folks and probably pushing them to worse quality of life, but we're also likely worsening the illicit drug crisis. And I think that's something that has to be highlighted because right now, well-intentioned people believe that they're trying to fight addiction, and they believe that by being so stringent on the opioids, they're doing that. But in fact, right now, the pendulum has swung so far the other way that they're actually doing quite the opposite.
Awesome, and thank you for being here. We appreciate it.
Thank you so much for your time. So let's let Dr. Darnell tie it up.
Thank you. Well, it's been such a pleasure to speak to all of you and also listen to all of the great speakers. I just want to summarize a few points. I am a clinician who has been working with patients with chronic pain for the past 20 years in medical settings, both in acute pain settings as well as in outpatient chronic pain settings. And what we appreciate and really need our careful attention on is the individuality associated with treating pain. And this is a message that has really been threaded throughout this session, and it bears repeating. Each person has unique circumstances, unique diagnoses, a unique response to medication, and there is a fraction of patients who do well on opioids as prescribed for chronic pain. I want to implore us to keep the focus on pain management for patients who require analgesia for pain. This is really the most important topic of the day. And what we have seen is that through some stringent prescribing practices, policies, and board actions, we have seen stripped from physicians the ability to provide patient-centered analgesia. So the question was asked, what do we need and what can we do? Number one, opioid tapering is not right for all patients. So appreciating the patient-centeredness of response to medication and needs. We do need to apply patient-centered principles throughout the state of Oklahoma. Recognize that opioid reduction increases health risks for some patients, so that if the focus is on patient safety, we need careful attention on this issue and recognize that opioid reduction does not necessarily confer safety unless it is conducted in the right person and using the right methods. We can offer through Stanford University right methods if the state of Oklahoma is interested. This is a voluntary, pragmatic opioid tapering program that exists in 4 states. This is a federally funded project. We have a formula for patient-centered opioid reduction performed in voluntary fashion. We can provide the playbook, the electronic infrastructure to assure patient safety and careful monitoring throughout a patient taper, if that is so desired. We must monitor patients closely, very closely, in cases where opioid reduction is applied. And lastly, what we desperately need in the state of Oklahoma and beyond is policies that reflect patient variability and protect prescribing for patients who need opioid medication. This includes protecting the physicians and other healthcare clinicians who prescribe these medications. We need a system that assures that we can protect the medical decision making of the clinicians who were trained to treat patients and avoid a legislative approach to the care of citizens who are relying on us to keep them safe and to improve their health. Thank you.
Wow. A lot of information. Representative Marty, thank you, for letting us do this. This is very important to the state of Oklahoma and the United States. We are going to have downstairs a press conference at 3 o'clock in room 5G. We're not going to solve this today, but hopefully we open the door to better health care. You guys want to say anything? Okay. Thank you so much for letting us have this study.
Absolutely. Thank you for everybody that came, and we have another study relating to controlled dangerous substances starting at 2:30. So that'll start in just a second.
Come back.
Yeah. in alcohol, tobacco, and controlled substances. We've got Representative Rick West going to talk to us about controlled dangerous treatment centers such as methadone clinics, and I will let him take over, and you can go ahead and call your first person.
Well, thank you, Mr. Chairman. I appreciate it. I just want to, first of all, thank you for hearing this interim study, and I just want to appreciate everybody coming today that's going to speak, and just want to give you a couple of reminders. Speak into the mic. Everything we do is recorded, and what we're trying to do today is just to talk about some transparency issues that we think we have. The controlled dispensing, I believe that it's wide open, and then we need more legislative oversight, I believe, and hopefully with all the people that's going to speak this afternoon, that will give the committee some kind of idea of where we're heading with this. I got involved in this with a constituent and whose daughter passed away, Mark and Shauna McKenzie, and her daughter, their daughter Hannah. I've asked Mark. He got me involved in it, and I appreciate that he did. And I'm going to ask Mark, if he will, be the first speaker today. Mark, say your name and where you work and who you are.
Do I have to hold this?
No.
Okay. All right. First of all, we'd like to thank you for having us here today, taking away from your time. Trust me, I'd much rather be at girls' basketball practice as being intimidated in here. But anyway, this is my wife, Shanna. We're the parents of Hannah McKenzie. She was our only child, which she was, as our only child, she was our only world, not just our only child. I mean, everything we did revolved around Hannah. And she passed away from a methadone overdose on July the 23rd, 2017. And we would like to go back and spend a little bit of time on a little bit of the history of that day. On the morning of July the 23rd, 2017, the Pensacola police chief and the assistant chief were at our front door early that morning, and I knew something bad must have happened. They came into our house and notified us that Hannah had passed away. After falling to the floor in shock, you know, you never expect to hear that about your child. We had asked, how did she pass away? And they said alcohol, and that there was empty alcohol bottles found near her. They informed us that they sent her to Tulsa for an autopsy. Our daughter did have some issues with alcohol, and the police department knew that. So we thought that was what had happened. They told us we would have the results from her autopsy in 6 to 8 weeks, and they would get back in touch with us. Approximately 8 weeks later, we hadn't heard anything, and on a Sunday afternoon, I was working in my yard, and a DEA agent had stopped by and was visiting with me. And we were talking, and I told him that I hadn't heard back from Hannah's autopsy yet. He looked at me strange, and he said that he was at the medical examiner's office a couple of weeks ago in Tulsa, and he went in there to check on Hannah, and that her autopsy was complete, and they had sent it to the Pensacola Police Department. I told him it was alcohol poisoning, right? And he looked at me like I was strange again. And I asked him, I said, why are you looking at me like that? He said she didn't have a drop of alcohol in her system. I then asked, well, what did she die of? And he said a methadone overdose. I was puzzled because we had never heard of methadone before and knew that Hannah had never taken any methadone. Before that day, we had never heard of methadone. On Monday afternoon, after I got off my school bus route, I went to the Pensacola PD and asked Police Chief Steve Howard if Hannah's autopsy was back. He and the Assistant Chief, John Cheney, told me yes, it was. I then asked them how come I wasn't notified that her autopsy report was back. And they looked at me and told me that they didn't know how to tell me that her autopsy report was back. And I told them, I said, we can't sleep at night, and you're holding this information from us that you should have let us know that it was back. They didn't. And then I asked them if she had died of alcohol poisoning, and they like they had led me to believe that she had. And they said no. I asked them, then what did she die of? And they told me methadone overdose. I asked to see what methadone looked like, and they showed me a picture of Jeremy Odom's methadone bottle. It looked like a large pill bottle with some liquid substance in it. I then asked why wasn't someone arrested. I told them that Hannah had never used methadone before and that she didn't have a prescription or money to buy it, so someone had to give it to her. They said Jeremy Odom told them that he stole it from his safe. And I vehemently said that that's a lie. Hannah was no thief, and she hated thievery. They told me the methadone came from a clinic in Roland, Oklahoma. I asked them if they were going to arrest anyone. They said no. I then informed them that I was going above them to have something done about this. It just wasn't right. Then on Tuesday morning, I called Lou Randall, the investigator with the Attorney General's office. I told Lou the story about Hannah. She said she was sorry for what had happened to our daughter and that she would talk to her supervisor and get back with me within 3 days. And about 30 minutes later, Lou called me back and informed me that she was going to take Hannah's case. And what a relief it was to finally someone was going to try to get some answers of why our daughter passed away. I mean, we have never broken the law or been in trouble and always try to follow the law, but then the one time something happens and it just seems like it was roadblocks everywhere. This is where things got very upsetting. While Lou was investigating the circumstances around Hannah's death, I was busy Googling and learning what methadone was and how it was dispensed. While Lou was investigating, another young girl was arrested for possessing Jeremy Odom's methadone. Lou had charges brought against Jeremy Odom, which were manslaughter and illegally dispensing drugs, methadone, and he pled guilty. Lou came by my office after serving a search warrant one day. I asked what she had found, and she said that was the cleanest drug house she had searched. I asked who knew she was coming, and she informed me that she had contacted Police Chief Steve Howard the night before, and from that point on, she ran everything through a nearby city, another police department. I began asking people if they knew anyone that went to this methadone clinic in Roland. I was given several names. I asked these people how that works. They informed me that they get in line outside the clinic at about 4:15 a.m. There were approximately 75 people in line. They get up there at 4:15 a.m. to receive their methadone, and that they must pay for this methadone with cash. They also told me that any drug they want, they can get in this line. They said after a little time, they could get take-home doses and then sell it on the street, and that was a legal way to get dope. This is the people that I knew that went to that clinic. I couldn't believe this, so I went to the clinic on several occasions at 4 a.m. in the morning in a parking lot just right there by the clinic. Sure enough, I videoed several people lining up at approximately 4:15 a.m. There were approximately 75 people in line, and they went in one door, and in less than 5 minutes, they were coming out another door. Some would be carrying a little small black box, it looked like it was about that big, with them, and I was told that was their take-home methadone. Jeremy Odom was a customer there for 10 years. and had a 2-week supply of take-home even after failing 47 drug tests. This guy had failed 47 drug tests and was given a 2-week supply of a medicine that kills people to take home. He wrote himself a note saying he was babysitting his deceased grandfather. I thought what small regulations I did, I thought a requirement was for them to have a job. No, not when you're babysitting your deceased grandfather, you know. I just could not believe, as could anyone else, that I would tell this story to, that these clinics and customers, and I will never call them patients, I will call them customers if they're lining up at 4:30 in the morning and paying cash for a product and walking out the door. That's not a client or a patient, that's a customer in my opinion. They have zero compliance checks or regulations. Even drug courts have compliance officers that do weekly home and work checks for people that are in drug court. I've been working at Pecola Public Schools for 28 years. Went to school there since kindergarten, and on October the 13th, just recently, I had to be fingerprinted because of House Bill 3398 or lose my job. I have obeyed the law my entire life, and I still have regulations to follow. Why don't these facilities? I'm on a random drug test to drive a school bus. If I fail that drug test, I don't get to drive a school bus. I have regulations and rules every year with my job, and they have any. There must be some rules and regulations for methadone clinics. A state board that has oversight and can perform random checks and audits of each clinic to protect the citizens. Currently, there are more laws to protect the customer buying these drugs than laws providing safety for the community or someone like our daughter, Hannah. Law enforcement can't even go on the property of these clinics. That's a shame. In closing, these methadone clinics, in my opinion, are nothing more than legal drug dealers with zero regulations. I have to go to the doctor and to the pharmacy to get cough medicine for a sore throat, but they can dispense methadone for cash at their facilities. I firmly believe that rules and regulations on dispensing methadone should be in place, and a state agency that is allowed to do random checks and audits of these facilities, maybe even the IRS. Also, every time methadone is prescribed to these customers, it should be entered into the PMP. Right now, I don't believe there's any laws that would keep a person from going to the clinic in Roland, Oklahoma, getting methadone on Monday, 2-week supply, then going to Tulsa Tuesday, getting them another 2-week supply, then going to Oklahoma City and getting prescribed opiates from a family doctor. There's no regulations. It's like the Wild West with these methadone clinics. And I can't believe that in the state of Oklahoma, to get sore throat medicine, I go to a pharmacy and a doctor, and to get methadone, a drug that kills citizens and killed our daughter. And I know some people's going to say that methadone's a good drug. I don't know if it is or not. But I do know that what I saw over there, the mornings I went over there at 4:15 in the morning, was not someone with cancer or needing help from this drug. I promise you. And we're in another case right now, and we're sitting in court 2 weeks ago. And this lawyer for these clinics, and we're following everything that the state tells us to do, and he kept putting it all back on the state of Oklahoma, which I believe he may be correct. He may be following everything the state of Oklahoma tells them to do. But it's sad when we have to go to court because they weren't giving up any information on their financials or their records or anything, and a judge has to order them to give those things over, in which the judge did order them to do that. But there has to be some kind of regulations where, in my job, in the State Department of Education comes 2 or 3 times a year, and we have to give all these reports and things to our accreditation officer. If we don't have all this stuff in line, we lose our accreditation with the state of Oklahoma. These clinics have zero. I don't know of anyone regulating them or forcing them to have any policies or rules to follow. And I know we're never going to beat grandparents, she and I. But if we can stop this from happening to some other family, I think that as elected officials and people that try to do right in our state, it's our job to protect people, not one company or one entity that can go by and do anything they want and kill our kids. It's just not right. And I don't know. You guys know a lot more about the legal systems and what needs to happen, but there's got to be some kind of regulations for these people.
Well, Mark, I want to thank you for your testimony. I think everybody here understands or tries to understand what you've been going through for the last few years, and maybe from this interim study today, maybe we can go to work on that and try to put some teeth in some legislation. And I appreciate it. Next is Lou Randall. As Mark said, that she was the investigating officer for the Attorney General's office. Lou? Yeah, just slide right down there. Or you can stand up there if you'd like.
My name is Lou Randall, and I'm an agent with the Attorney General's office. And I hope you guys don't mind, but I'm going to read this because if I don't read it pretty much how I've laid it out, I will miss a point. So, Mr. Chairman, legislators, thank you for the opportunity to speak. My name is Lou Randall. I have been in law enforcement for 19 years and currently serve as an agent for the Oklahoma Attorney General's office. Over the course of my career, I have experienced many joyful moments. Accordingly, I have experienced many more moments that I pray no one would have to endure. I'm not saying this to represent anything as it relates to me, but rather how tragedy affects families and loved ones. It is my experience with tragedy that brings me before you today. Mark and Shanna McKenzie have experienced one of the greatest tragedies I can imagine, the loss of a child. Apart from their pain, I see corresponding tragedy in that their grief is one that is repeated time and time again in families throughout the state. This pain has also touched my family, so I come before you today not only as a law enforcement officer, but also as an Oklahoman affected by this crisis. My intent today is to bring awareness to the situation that needs change. I recognize the importance of medication-based treatment programs. I have the unique perspective to see where meaningful programs can be exploited and abused. It is my belief the implementation of new legislation that will provide a system of checks and balances to methadone clinics that will allow the rehabilitation process to work more effectively and provide the support to those in need. On October 11, 2017, I received a phone call from Mark McKenzie. He told me about the death of his beloved daughter, Hannah Ray McKenzie. Hannah was a beautiful and spirited 23-year-old. Obviously, Mark was upset by the death of his daughter, but he was also upset because her death was referred to as an accidental drug overdose. Mark believed there was more to Hannah's death and felt there needed to be an investigation. He requested the assistance of the Attorney General's office, and I was assigned to the case. Hannah suffered from bipolar disorder, which manifested itself when she was approximately 18 years old. From that time, Hannah started having substance abuse issues combined with her bipolar disorder. Mark and Shanna were totally devoted to helping Hannah get the substance abuse and mental health treatment that she needed. On July 18, 2017, Hannah completed a rehabilitation program in Pompano Beach, Florida. At the time of her discharge, Hannah's medical records revealed she tested negative for the presence of illicit drugs. Hannah returned to Pensacola, where she lived with her mom and dad. On July 23, 2017, Hannah was found dead in the home of Jeremy Odom. Jeremy lived with Jennifer Hobbs, his aunt, and Bert Wisdom, his cousin, in a house that was known to local law enforcement as a drug house. At the time, Jeremy was a methadone patient at Oklahoma Treatment Services, also known as Right Way Medical in Roland, Oklahoma. Jeremy was at a stage in the program where he was allowed to be on a take-home status. This meant when he had an appointment, he would receive one dose at the clinic and then be provided a bulk amount of methadone with the expectation that he would secure the controlled substance at his residence and adhere to the appropriate dosing until his next appointment. When police arrived to investigate Hannah's death, Jeremy gave statements that he and Hannah hung out together and had fun. He said they watched movies, partied, and Hannah ended up staying the night. Jeremy said he drank 7 or 8 beers throughout the day. The beer mixed with the methadone caused him to pass out around 10:30 or 11 p.m. Jeremy said he woke up the next morning and found Hannah unresponsive. Jeremy informed the Pensacola police chief that he was a patient at the methadone clinic and told the chief that his methadone was in his room in a black lockbox and that he takes it daily. Jeremy said there were 3 bottles inside the lockbox, but there should have been 12 or 13. He stated 2 of the bottles were half full and 1 bottle was unopened. Officers recovered multiple syringes, a crystal-like substance, and other drug paraphernalia. The bottles recovered at the scene were dated July 21, 2017. That date was Jeremy's most recent appointment at the methadone clinic when he would have received his weekly doses. This meant that within the 2 days prior to Hannah's death, Jeremy had consumed or otherwise exhausted 6 days' worth of methadone. Pensacola police officers also found an empty methadone bottle belonging to someone other than Jeremy. I eventually tracked down that patient and conducted an interview. That patient's story contradicted Jeremy's story as to how the bottle ended up in his home. Regardless of the truth, that patient was on the take-home status as well, and somehow the bottle was found in the home of Jeremy Odom, who was known for abusing, selling, and trading his methadone. The Oklahoma Chief Medical Examiner's Office report listed Hannah's probable cause of death as a methadone and methamphetamine combined toxicity. During an interview with Dr. Byron Curtis, the chief toxicologist at the ME's office, he stated methadone amounts of 0.10 are typically fatal. Hannah had 0.33 in her system when she died. Dr. Curtis said Hannah had a small amount of methamphetamine in her system. However, the methadone in Hannah's body was more than 3 times the amount of what is considered fatal. During the investigation, I interviewed Jeremy's cousin, Bert Wisdom. Bert told me that Jeremy sells his methadone and uses the money to pay for his clinic cost. Bert admitted to personally assisting Jeremy with the sale of his methadone. He said Jeremy has been selling his methadone nearly as long as he has been going to the clinic. On December 4, 2018, Jeremy Odom was convicted of second-degree manslaughter for his role in Hannah's death. I understand that actions have consequences, and it would be convenient to say that Jeremy's conviction is an example of justice being served. But if we do not look beyond conviction, then we will overlook the failures of a well-intended program that is often exploited. While my job is to identify and investigate criminal acts of prosecution, I am not here to assign an individual blame. In addition to individual accountability, the circumstances that led to Hannah's death can be attributed to failures within the system of medicine-assisted treatment. I spoke to numerous individuals throughout this investigation, including former and current methadone patients. The patients were more concerned about having a positive urinalysis for methadone than about the consequences for having a positive urinalysis for illicit drugs. A negative result would indicate the patient was diverting their methadone and could result in removal from the program. Those who abused the program and sold their methadone typically held back doses or partial doses so their urinalysis would show positive. The system is so widely abused that it is common to purchase or trade for urine in the parking lot. Patients could also purchase or trade for narcotics while waiting in line. Since many patients do not have jobs and money, they engage in a bartering system. All too often, it seems more important to maintain the status quo rather than recovery. Unfortunately, this often holds true not only for the patient but the clinic too, where it seems the profitability of continued failure is more important than success. As unbelievable as that sounds, I learned that Jeremy failed 47 urinalyses. How is it possible for a patient to maintain the take-home status after being totally uncompliant with the program? The take-home status should be a privilege afforded only to those that follow the rules and their progress reflects a true movement toward recovery. In my opinion, he should have been dismissed from the program. I'm curious what types of behavior would it take to actually get dismissed from the program. At the time of the investigation, Jeremy paid $9 a day for his methadone. Even though $9 a day does not sound like much, Jeremy was unemployed and without legitimate income to pay for his methadone. He could sell one bottle for $100. Apparently, no one questioned how he was obtaining money to pay for his treatment over the course of 10 years. In my opinion, providing rehabilitation to addicts involves providing resources that will assist them in all areas of their life, which includes employment. As research has shown, lack of employment can lead to financial hardship, which can lead to depression and then drug use. This cycle can create the unhealthy choice to sell their methadone just to stay in the program. By intervening and implementing stricter guidelines for employment, patients can possibly change multiple aspects of their lives. The Roland Police Department is acutely aware of how the lack of compliance for methadone clinics adversely impacts a community. Officers of Roland can attest to the number of intoxicated individuals that leave the methadone clinic. In Roland, it is common knowledge to law enforcement that the methadone patients typically leave the clinic and then stop at the nearby convenience store to abuse the substance. The store's employees are often left to clean up blood and drug paraphernalia that is left behind. This unsanitary problem is a hazard for those responsible for cleaning the mess and those that unknowingly come in contact with the blood left behind. Jeremy was a methadone patient for 10 years. Accepted medical practices suggest the initial dose of methadone should not exceed 30 milligrams. When Hannah died, Jeremy's dosage was more than 3 times that amount. The clinic increased the amount of methadone rather than trying to achieve sobriety. The treatment goals seem to have changed over time. Today, these programs are called maintenance programs. If addiction is being maintained, then how can anyone successfully recover? When an individual has signed a contract for pain management, there are rules that must be adhered to. Legitimate pain management programs utilize what is known as a pill count to ensure patients are taking their medication as prescribed. Patients who violate their contracts are released from the program. Random medication checks would be extremely beneficial of methadone patients that are on the take-home status. The term unsupervised approved use of medication is commonly referred to as the take-home status. One of the requirements is the absence of recent abuse of drugs, opioid or non-narcotic, including alcohol. As previously stated, Jeremy tested positive 47 times. I do not understand how he remained in the program as long as he did. Like random pill counts, methadone clinics could require patients to comply with random UAs. This practice is routinely utilized in drug court programs. Patients should have no indication of when they will be notified about submitting a urinalysis. Within the last year, I received concerning information about Oklahoma Treatment Services in Tulsa. I was informed that clinic was dispensing take-home methadone prescriptions in cardboard Kleenex boxes. I hope that everyone here is alarmed by the idea that a highly potent medication is being dispensed in a Kleenex box. I am trying to understand how there are no regulations on the dispensing of such a dangerous medication. I am sure that several people in this room are taking some type of prescribed medication. I, for one, am. When I go to pick up my medications, I always observe them to be in a bottle with a child-proof lid. I am referring to routine medications, not narcotics. Random compliance checks with consequences to the clinics could be a step in the right direction towards safe dispensing procedures. The Oklahoma Bureau of Narcotics and Dangerous Drugs has a drug monitoring program known as the Prescription Monitoring Program, or PMP. This program involves real-time reporting of controlled dangerous drug prescription information from dispensers for the purpose of protecting against diversion. This simply means that if my doctor prescribes me a controlled drug, my personal information pertaining to the dispensing of that medication will be available for doctors and other professionals to view. This information has become more relevant since the emergence of the opioid crisis. How does this relate to methadone clinics? Methadone is not reported to the PMP. Therefore, a methadone patient can obtain methadone and other Schedule II narcotics without alerting a doctor. In the last couple of years, Oklahomans have seen the rise and increase of medical marijuana businesses. Currently, the state of Oklahoma has established the Oklahoma Medical Marijuana Authority, OMMA. The OMMA is responsible for licensing, regulating, and administering the program as authorized by state law. Their website states, operating under the Oklahoma State Department of Health, the primary goal is to ensure safe and responsible practices for the people of Oklahoma. Methadone clinics have been around for many, many years, but there are no guidelines or regulations. I believe it is time that Oklahoma takes a step toward protecting all Oklahomans and not just those addicted to opiates. In closing, I want to convey to you that I am supportive of rehabilitation. While my job has led me to relate almost exclusively with negative outcomes, I realize there are people that successfully recover from opioid addiction. I also know there are many programs that focus on recovery instead of profitability. I believe individuals who recover from addiction have achieved their success by being compliant with structured programs. Although I have referenced Jeremy Odom extensively, the truth is he is irrelevant to this conversation. His name could be replaced with any number of names, but he serves as an example of the outcome we can expect if the current system is not changed. The implementation of guidelines and regulations will not hinder the programs that are already providing structure and focus on recovery. They will, however, be a deterrent to programs that prioritize profitability over sobriety and systems where abuse can lead to tragedy. Thank you for allowing me the privilege to speak before you.
Thank you, Lou, for your very knowledgeable and well-presented report. I really appreciate it. I think we heard in that report some things that Oklahoma needs to take a look at and regulate. Thank you very much for your time. Our next speaker today is Stephen Cepoloni. Stephen is with Fort Smith Behavioral Health. His wife is a pharmacist. Stephen, you're recognized.
Yes, my name is Dr. Cepoloni. I own 2 treatment centers that border Oklahoma and Arkansas. I'm a resident of Tahlequah, Oklahoma. In my discipline, I kind of look at like problems and solutions. So I am just going to present this the way I would in my discipline. First thing, I'm going to go over what I think 3 of the problems both Mark and Lou pointed out. Okay. There is no regulatory agency such as the director of the Oklahoma State Bureau of Narcotics and Dangerous Drug Control that provides oversight of the practice and procedures of the administration and dispensing of medications during opioid antagonist treatments in the state of Oklahoma. Methadone, which is a Schedule II drug, is dispensed at opiate agonist treatment programs in the state of Oklahoma without documenting the medication in the Prescription Monitoring Program, or PMP. prescribing physicians have no limitations on the number of patients receiving the opioid agonist prescription of methadone. Now, there's some proposals that you can look at that may benefit or create some safety and regulations around this. First, delegate a board to consult with regulatory agencies and develop indicators for level of prescriber or patient activity that suggests where potential harmful prescribing patterns, drug diversion, or abuse may be occurring. Second, you got to give this board some kind of teeth where they can actually do something about it. Empower a board with the ability to regulate the prescribing of opiate agonists and other controlled substances by physicians and their delegates. Both random and scheduled inspections and investigations conducted by said board will include the board's ability to use subpoenas for immediate production, inspection, and copying of medical and billing records to adequately regulate the prescribing of opioid agonists and other controlled substances to protect the public health and welfare. Finally, in conclusion, I would just say controlled substance modernization is needed to improve transparency and oversight of narcotic medications and medication-assisted treatment settings to reduce diversion and improve public safety. Thank you very much for letting me speak.
Thank you, Doctor. We appreciate what you said. I'm sure that the committee might have some questions for you when we finish up, if we have time. Our next speaker is Marty Hendrick. Marty is very familiar with where we're at today at the Capitol. He's Executive Director of the Oklahoma State Pharmacy Board. Mr. Hendrick, you're recognized.
Thank you. I'm Marty Hendrick. I'm the Executive Director for the Oklahoma Board of Pharmacy. I've been in this position for about 3 years now. Before that, I worked as a pharmacist out there in Tulsa. Worked out in Wilmington, North Carolina. I can tell you those are two of the epicenters for opioid crisis. So I got to see two of the top 10 definitely out there. And the first thing when I heard this story, and Mark, I know that's a hard story to tell, but it affects all of us too, and I think it's an important message to get out there, is that there's a part that is out there that we don't really talk about. And I can tell you, as myself as a pharmacist, when I first heard this and taking everything as a pharmacist, is so where is the regulation that's going on here? Where is the checking to make sure we're doing things by the book and make sure that we're doing stuff above board? Where are those checks? And my first thought was PMP. Obviously, this should be catching these things. So I started thinking back in my retail history not so long ago, and I don't ever recall seeing those things there. And I thought, as a practicing pharmacist, how important those things would be as key indicators. And you alluded to it earlier. If someone were to pick up methadone in Tulsa, and then let's just say go and see a physician in western Oklahoma and then pick up an opioid there, well, what we're really doing is counterproductive. We're not curtailing, we're not stopping, we're not preventing. So PMP essentially was a tool that was created to prevent these things from happening, for a doctor to review, a pharmacist to review, and look at that information and say, obviously, this patient doesn't need that medication going forward. Or I may need to call the doctor, have a discussion with them. This patient received methadone. Are you sure this is the path that we want to go by? But when you're not giving that tool, then how can you succeed? And by no means is PMP perfect. It was a great idea, and it still is a great idea when it first came out on the scene. And I think, as we've evolved, we haven't necessarily evolved PMP with it. We haven't learned from our mistakes, I guess more importantly is to say. And sometimes I would say if we write a rule, we have to think about the consequences that come with that rule. There's always hidden things that we don't think of at the time. And later on in hindsight, when we look at it, it becomes a clear picture. And this is a clear picture to me. I think what we revert back to is in 2016, you started seeing a lot of federal regulation with PMP and the control of PMP. And I know some of these things were for protection of the patient, but I'm still perplexed by what we're protecting if it's all HIPAA protected anyway. We don't give information out to a patient on their PMP. That is the sole propriety of the doctor, physician, pharmacist, and sometimes law enforcement. So I'm perplexed why we wouldn't share that information and why that information wouldn't be available out there, because I think we're missing a huge boat here of information that's out there that's just waiting for something bad to happen, because you're going to have entities that don't have that information. Like I said, it could be a physician that sees a patient that totally presents with the problem and writes a prescription. It could be a pharmacist that fills that prescription, has no information to go on but what they see in the PMP, and goes ahead and dispenses that medication. And in the end, what do we have? Possibly a fatality for a patient that it didn't need to happen. So we talked a little bit about earlier, solutions. And I totally do think there needs to be some kind of oversight over this, some kind of regulation. I think back to the Board of Pharmacy, we did, I believe, a little bit of inspection of doctor dispensing, but that would have been 2016 or before. Probably 2015 was probably about the last time we were seeing that out there. And by no means am I saying that we need to go into every physician office, but I am saying that there are some entities out there that obviously maybe we made a misstep here and we're just not providing the right material and people in place to assure that everything's running correctly. I'm not saying whether a methadone clinic is bad. I think there are positive outcomes. I've seen the bad of it too. I've seen Suboxone clinics that patients never seemingly got off that medication. And they would always tell me, it's going to be next year, Marty. He's working me down. And the dose would never work down. And I remember one patient, and I vividly remember this gentleman. He was in his early 20s on Suboxone. And we just calculated how much he was paying a year. And I said, Jeremy, you're paying over $30-some thousand a year on this. This is a lot of money that you're taking out of your pocket. Is your doctor working you the right direction to get down? Because I've never seen your dosage move. Yep, Marty, I'm sure he's going to give me 2 years. Hey, Jeremy, you're still paying $35,000 here. Wouldn't you like to have that in your pocket? I mean, that's a lot of money coming out of your pocket for this stuff. He's going to get me off. One day, I was visited by DEA, and they wanted to know why our store dispensed so much Suboxone. We were right by this clinic, and so I went down there and went to view the clinic. And to be honest with you, when I went in there were people on the floor, people in the parking lot. It was a scene that you described. And I knew in my heart that there was nothing good coming out of there. And, we sent that message out, but that message was never heard. And so I'm still perplexed at the problem. And do I have the right answer? No, but I do think there needs to be some sort of oversight here to start evaluating. I can tell you how many times as a pharmacist I've counted somebody's pills to make sure they were on top of what they were doing. And as pharmacists, we do that. It's just something that's ingrained in us. We look at days' supplies. We're very questioning of patients, too. Mr. Blah, 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 do you know why the doctor prescribed this for you? Do you know this might interact with this? We look at all those things. So, I'm still perplexed why we wouldn't be given that information for PMP, because that's a huge missing puzzle there. And my next question is why do we not have more involvement? And the federal piece may be kind of the question and answer here. As I thought about it a little bit, you would really need an entity that could work with both, because you're going to have to toe the line on both ends of that, and that's federal regulation allowing state regulation to join in with it, and to have a good enough relationship with the federal government or whatever entity that is overseeing that those two agencies or those two entities can exist together and exist for betterment. I think that can happen. I don't think it's easy, but I think that definitely can happen. So I'm going to leave it with that, and if you guys have questions afterward, I'd be happy to answer them.
Thank you, Marty. I appreciate that. Very knowledgeable, and for if nothing else comes out of this, certainly got some experts here today that testified. Got the big guns in here, and I really appreciate y'all's time to to come. Our next presenter is Pat Hall. Pat is with the Oklahoma State Medical Association. He's a task force lobbyist. Mr. Hall, you're recognized.
Thank you, Representative West. I'm going to, yeah, please, to you all and anybody in the audience that wants them, except for Lyle Kelsey.
Did you get that joke?
Thank you. My name is Pat Hall. I'm lobbyist for the Oklahoma State Medical Association. And for the last 5 years, I've been one of the lead lobbyists on opioids reform in the state. What we're passing out today is really...
Pat, can you turn your mic on for us? And state your name again.
My name's Pat Hall. I'm the lobbyist for the Oklahoma State Medical Association, and for the past 5 years, I've been one of the lead lobbyists on opioids reform. What I'm passing out today is the 3 parts. The first part is actually the history of opioids reform in Oklahoma. We thought the members of the interim study would want that, as well as maybe some of the others in here. The second part of this is kind of really the staggering data, what's happened on pills and MMEs and overdose. And the last one is some of the recommendations from the Oklahoma State Medical Association and others on what we think next steps should be. I have to give not credit to this, but after hearing the coach's, Mr. McKenzie and his family's story, we went back and kind of to start there is none of us that have been doing opioids reform for the last 5 years, starting with PMP and on, have really looked at Suboxone or methadone. I think it's something that most of us took for granted. That it was a regulated industry and nobody's fault. It's not part of the PMP, and we'll get to that in a second. The history is pretty self-explanatory. I think the second part of this is the data on Oklahoma, and I do give credit to our good friends at the Oklahoma Bureau of Narcotics and Dangerous Drugs, especially how well we've worked with Mark Woodward over there over these 5 years as part of a coalition in the Oklahoma Osteopathic Association, the Pharmacy Association, and all of the other groups. Also, the previous interim study today that we have recognized also as the coalition that we do need to work with also those patients. We've met with grieving families for years, very powerful people in Oklahoma, but we've never had those that actually have been users of opioids for many years included in the coalition. But you can look at the number of pills from 2015 to 2020, the decrease in the number of opioid pills has been 39%. Previously, we've also said that really this legislature can't control the illegal. They can try, but that the medical profession, the osteopaths, the medical doctors, the dentists, the veterinarians, and those that are prescribers have very little input except for our legislative skills to have input into of the fentanyl coming from China, the fentanyl that's coming into the state. So we've concentrated on hydrocodone and OxyContin. You can also see the decrease in the pharmacies, the MMEs, and then the key to this one is the overdose. It decreased 2017 to 2019 by 25%, significantly better than the U.S. average, and in 2020 it increased, but that was during the COVID. What I would like to concentrate on, and I'm glad Chair is here, Representative Marty, since he is the author of the pain clinic legislation that we've been working on for several years. He just took over authorship in the House late last session. We're continuing to work on this. I will point out that especially in Roland, it's come to our attention over the years that most, if not all of those clinics are not owned by MDs or DOs, veterinarians, or dentists. They're owned by out-of-state corporations, out-of-state individuals, and others. So if you really want to make a dent into this and talk about some of the things that you've seen and others have seen, especially agents with the Oklahoma Bureau of Narcotics, the Attorney General's office, and others, if you want to see them laying on the floors and you want to see them stacked around the building giving cash out, I think you'll find that most, if not a majority of those, are not owned by those that actually have a DEA license. They're the prescribers, those that have a DEA license, but they're not the owners. You'll see in many of those clinics they have Rent-A-Doc that they brought in on 90-day certificates and others that are actually doing the prescribing and will leave Oklahoma again. So we think one of the main things, and I think I speak for certainly the Medical Association and the Osteopathic Association, if you could do one thing next session, we could talk about pain clinic ownership. We would like 51% of all pain clinics to be owned by medical doctors or osteopathic doctors, but Representative Marty, it's negotiable. So, kind of an inside, but we're making progress. In the next one, PMP for methadone. It's been said here many times today. I think that is a no-brainer. That's an easy place to start. Sadly, it probably does take legislation to increase the list, but you could use the pain clinic bill. It's ready to go in conference. You could just amend that bill and add methadone to the PMP. The third one we have is dispensing by prescribers. It's something that we would just like to have a continued conversation on. I would recommend that you not in any way talk about veterinarians, that they're a whole different class of prescribers. But I think medical doctors, dentists, and osteopathic doctors would certainly be welcome to have a conversation, be included in that conversation on who can dispense. I think you might want to also look at cash for Schedule IIs at pain clinics. You wouldn't want to look at cash for Schedule IIs at pharmacies and some other places, but I think that's a discussion that you could have to try to limit some of these problems by limiting cash transactions. The AG is a continued champion on this. It becomes very important for the Attorney General's office to continue to work with the Oklahoma Bureau of Narcotics that we can stop some of these rumors that get out there on the law enforcement side, that we have direct communications on this. The last one, we have the continual active involvement in the medical community. I think we have found that the more the medical community is at the table along with the pharmacies, having these conversations, working with the different law enforcement groups, the faster we can come to legislation. And it can be without, it can be a really universal cooperation instead of confrontation in these types of pieces of legislation. I would like to open it up. The discussion is not on your list, but I would like to open it up again. We've had it on here before. The patient access to their PMP. I'm not sure that that's the best idea, but I'm not sure it's the worst idea. I certainly think it's something that others could talk about. I agree with Marty. It's something that certainly that should be discussed. The patient advocates really would like to have that discussion as well. That why don't they have access to their own PMPs, knowing what's in the PMP? I don't know that we have a good answer why or why not. So I think that would be fair. At the appropriate time, Representative West, I'd be happy to answer any questions.
Thank you, Mr. Hall. I appreciate it. Very good report, and I'm sure there'll be questions asked of you. Next presenter is Lyle Kelsey. Lyle is the Executive Director of the Medical Board. Mr. Kelsey, you're recognized.
You bet. Thank you, Representative West, Representative Marty, other members of the committee and guests. Lyle Kelsey, Executive Director for the Oklahoma Medical Board. I've been there a number of years. And Mark, every time I hear your gut-wrenching story, I am touched by that. I've got one daughter, myself. After my wife died just last year, she's moved in with me, and I cannot imagine anything worse than also losing your daughter. So I appreciate your continued fight for that. I don't think there's too much more I can add other than just kind of reiterate some of the things that Marty and Pat and Lou and some of the other ones, listening to Lou's summary again, is there's, the sad part about it is there's a lot of Hannahs out there and a lot of other boys and girls that are being caught in this mess. And it needs to stop. It's a tough tough business, and unfortunately, there's always people, as Lou has pointed out, that want to take advantage of the situation in other individuals, and that's a sad commentary on their life. I will also tell you that medicine in Roland, Oklahoma, is a black mark on Oklahoma and Arkansas. I just kind of went through my head as all this discussion was going on, and I know of 6 medical doctors that we've either revoked or had their license surrendered from Roland, Oklahoma. And most of those, they were not methadone. I'm not that familiar with the methadone clinic per se, but I'm certainly well familiar with opioid prescriptions and so on. And I'm sure there's probably other Rolands in Oklahoma, but I hope not. The things that we're seeing, as Pat pointed out, the minute we go in and take care of one physician, another one moves in and oftentimes doesn't have a clue of what's going on in that clinic until it's too late. So the PMP, we like the PMP. It's a great tool. It is a great tool for doctors. And I will tell you that many doctors that I talk to use it all the time, not only from a prescribing standpoint, but also for education to their patients. They give them copies of the PMP, show them where they've gotten, some of them unbelievably, 50 and 60 other doctors that they're getting medications from. I mean, now a lot of that stopped now because of the PMP, quite honestly. But we still have some of it, not near to that extreme, fortunately. But it's a great tool. I agree with Pat, and I didn't catch the doctor's name, but I agree with his 3 positions as well. But in that the PMP needs to regulate methadone. We'd like to even see something as far as marijuana, but I would imagine that's going to be much more difficult because of very little science to back it up. But the times that we operate on complaints against medical doctors and the other 14 licenses that we oversee, but most of the time the serious ones like this come from, for instance, like with Roland, Fort Smith Police Department, DEA, OBN, the DO board. We all consolidate together to work on these things and try to figure out some way to resolve some of the errors that we see going on. It does need, methadone clinics do need to be regulated. It's astounding that there's not more regulation for them now. And Representative Marty, I would say the same thing. If you can get some motion on that legislation, that would be great. Discipline in any factor, whether it's over methadone clinics or with us, and doctors has to include both the medical professions, but also strong law enforcement and a strong AG's office to help us control it. It's a tough deal. We have to have more controls on medications, and just like some of the legislation that's already been introduced, we're seeing the impact in prescription medicines, controlled substances. Unfortunately, we're seeing the street drugs increase, and that's another issue. So with that, Representative West, I'll answer questions or be available to answer any questions, but I think you've got a pretty good indication of where things need to go.
Yes, sir, I would agree.
Thank you.
I would agree with that. Regulation seems to be the topic, the word that we hear most of all. And I think to show the committee and to the other members how important that I think this legislative this interim study has grown into. Lori Carter is with us today, and Lori is from the Attorney General's office. She is Deputy Attorney General and Legislative Liaison, and she has made a really effort to get here. It's been a very busy day for her, and Lori, I really appreciate you coming, and Ms. Carter, you are recognized.
Thank you, Mr. Chairman, Mr. Vice Chairman. Like the good representative said, I'm the Deputy First Assistant Attorney General for John O'Connor, who was appointed this July. But through our previous Attorney General, we had sort of a three-pronged approach to the opioid crisis that we've been facing. The first prong was through legislative and policy recommendations through the Opioid Commission, the Oklahoma Commission on Opioid Abuse, which the Attorney General led up. The second was through litigation against opioid manufacturers and distributors, and the third is through law enforcement. As far as the litigation is concerned, we sued the leading manufacturers of opioid pain medication, claiming that the years and decades of deceptive marketing by these manufacturers created an ongoing public health crisis that continues to devastate the lives of Oklahomans as well as people nationally. We sued Purdue Pharma and got a big judgment that will ultimately, hundreds of millions of dollars will go towards treatment and research of opioid addiction. Some of that money also will go to helping political subdivisions around our state. We've got a fund for that. About $22.9 million will go towards that, and I'll talk about the Opioid Abatement Board in just a minute. We've also got the pending litigation against Johnson & Johnson, which is still on appeal, so we're hopeful. That was the $567 million judgment we got through a trial in 2019, and it is still on appeal. It was reduced by $100 million. It's about $465 million, I believe. So we're still working through that. The next point I wanted to talk about, well, the Opioid Commission, we had several pieces of legislation that went through that were recommended by the Opioid Commission. I don't know if any of that has been talked about at all. Concerning pill limits, electronic monitoring, or e-prescribing for pills, the Good Samaritan Law, which allowed, if you've got someone who's overdosing, they won't take into. Lots of times people feared being arrested if they called law enforcement for help or medical help, but they won't be arrested if you meet certain conditions, so that they don't have to fear calling for help if they're experiencing an overdose. So those are the two parts of what we do, and the third is law enforcement. And I know Lou spoke to you earlier about what our office does. We are investigating. We use our multi-county grand jury, who has jurisdiction in all 77 counties, to work with OBN and other law enforcement to prosecute those doctors whose actions are highly outside of what is allowed under the law. We like to say, 99.9% of the doctors give great care to their patients. But for those that don't and have killed their patients, we believe that, they should be held accountable for that. I've not sure how much you've talked about regulation of opioid treatment programs, but my knowledge is that they are regulated by the federal government, Title 42. They get certified through SAMHSA, but they are required to comply with state laws as well. But that's pretty much all I can offer on that. I'm happy to take any questions about anything we've done.
Are there states that require them to do more than the federal government? I mean, do we know that?
I don't know, but we could sure look into that.
Okay.
Go for it. You're recognized.
Texas is one that does that. There's a state that does that.
And specifically, do you know what, just off the top of your head, not, like, what do they do that you know of?
Now you're going to see where I cut and pasted.
That's fine.
This is what they do. They empower a board with the ability to regulate the prescription of opioid agonists and other controlled substances by physicians and their delegates. They also provide random scheduled inspections and investigations conducted by said boards, and they'll include subpoenas for immediate production, inspection, and copying of medical and billing records. Adequately regulate the prescribing of opiate agonists and other controlled substances to protect the public health and welfare. I got that. Now you know how I got it.
Thank you, Doctor. Attorney Carter, I should have addressed you that way. I'm sorry. Is there anything else you'd like to talk about, present to us today?
Just want to thank you all for letting us be part of this study. I think it's really important that you're looking at all these issues, and I think it's really important that all these legislators are here to listen and learn on this issue. I know it's hurt a lot of people. A lot of people have lost their lives, and a lot of people's families have been decimated by the opioid crisis. So it's really something important. Thank you for looking at it.
Well, thank you. Appreciate your time to come in today. I know it's been a busy day for you today. Our next presenter is Mark Woodward. Mark is no stranger to anybody probably in this room. Mark is with the Oklahoma State Bureau of Narcotics and Dangerous Drugs. Mark, you're recognized.
Thank you, and I appreciate the opportunity to visit a little bit from a law enforcement perspective and from the Bureau of Narcotics perspective when it comes to this and some of the opioid issues that we're dealing with here in Oklahoma. I'll tell you that you know, my 26 years with the Bureau, the first 23 of them, we were absolutely stretched as thin as could be as an agency dealing with the opioid crisis. Because so many of the new drugs that had just been introduced to the market, and it just created a new game for addicts to basically feed their addiction free of charge. And we've been dealing with that ever since. And since 2018, you know, Oklahoma's passed some fantastic laws, many of them which have been mentioned today with limits and other oversight, which has been fantastic. We've seen a stabilization in several drug categories, from prescribing to overdoses when it comes to prescription drugs. But unfortunately, it's sent a lot of our opioid addicts out onto the streets, and that is where a lot of the drug organizations out of Mexico and China have stepped up to basically feed that demand with fentanyl, and that is our new number one, I think, threat here in the United States is the black market fentanyl coming in from China. They're mass producing the raw materials that can be every bit as strong as morphine. It can be 1,000 times stronger than morphine. It can be things like omefentanyl, remifentanil, and carfentanil that can be 10,000 times stronger. And they will mass produce it, press it to, in many cases, look just like the M30 blue oxycodone. And here in Oklahoma, I can say just since May of last year, we're investigating 15 overdose deaths that are tied to those M30 pills and countless non-fatal overdoses. And side by side, you just can't tell the difference. And that's the go-to drug now on the streets in the United States because, again, the new laws have been wonderful, but these opioid addicts still had an addiction, but instead of scamming doctors, they're going to the streets and they're finding their drug of choice now being mass-produced overseas and sold very cheaply here in Oklahoma. The other thing is they're going to opioid treatment programs, and a lot of them are feeding their addiction through these programs. Now, many of them are very, very good, and at the Bureau of Narcotics, we've had some outstanding relationships with many of our OTPs, our opioid treatment programs in the state, but many of them, I can tell you, are basically fly-by-nights, and they are the go-to place, especially in Roland, Oklahoma. Our agency practically had to start an office out in Roland, Oklahoma, because we had spent 3 straight years out there dealing with many of the bad actors that have already been mentioned in this room today. And we would take one out, and the other one, somebody else would replace them overnight almost. And there was a 2.5, 3 year period out in Roland, Oklahoma, where we were doing investigations and surveillance, and we would see the same cars from places as far away as Louisiana, Mississippi, and Nebraska that would drive all the way to the same two places, because they knew who didn't ask questions, where you showed up, you brought cash, and you would leave with whatever you wanted. And they were absolutely doing no good to anybody with an addiction to try to get them off of it. They were absolutely feeding these addictions. And we ended up, as I said, taking action against some doctors, but they were just immediately replaced overnight because of the way these programs were run. But as far as the PMP and how that has been a game changer, the prescription monitoring program has been very, very helpful when it comes to a lot of our physicians, their guts telling them these people are scamming me. I don't have a way to basically find out if this person is telling me the truth. Are they in true pain? Are they trying to feed an addiction? And so in 2006, our prescription monitoring program became one of the first in the country that was real time, and not only did we track the Schedule II drugs, which were the most common then, but expanded to tracking 2 through 5s. And Representative Sue Tibbs in 2007 worked with us on legislation to make it mandatory checks, because we had physicians that were actually using things like methadone for pain management, and it was causing just an absolute spike in overdose deaths across the United States. And so we were able to get legislation out of this body to make methadone for pain management entered into the PMP, but doctors, again, over time started phasing that out. And so we really don't have that kind of tracking when it comes to today's methadone treatment programs and Suboxone programs. And the hurdle that we do face, and I know everybody in this room would love to see the PMP track methadone and Suboxone, it is, as it's already been mentioned, it's a federal oversight. And that includes federal regulation in CFR Title 42 2.36. It says that if states do have a prescription monitoring program, Suboxone and methadone clinics are permitted to report to the PMP, but they must obtain the patient's consent. And right there, that hits a dead end right there, because we're not going to get the patient's consent. So that is the hurdle that we face, is we're going to have to change federal regulation with that particular line within 2.36 on the federal Title 42 before we could do just a blanket legislation up here to require reporting to the PMP here in Oklahoma. One of the things that we think is going to contribute to helping from a law enforcement perspective is if we know how much is coming into the state of Oklahoma, methadone, Suboxone, and any other drug manufactured outside the borders of our state. Last year we had Senate Bill 241 that would require all CDS manufacturers and distributors to report the controlled drugs that they're shipping into our state that would be reported to our PMP. And we think that would be very, very helpful. Right now, some manufacturers are reporting, but they only have to report certain types of data. This would require all types of any CDS that's coming into the state of Oklahoma to be reported to our agency. That way, if we are investigating whether it's a pain management clinic, a drug treatment program, or even a pharmacy, that there's overprescribing or the scammers have figured out a loophole to exploit, one of the things that would help is knowing how much is coming in and how much is being distributed in the state of Oklahoma, and being able to investigate those discrepancies would be incredibly helpful. And that bill is actually sitting on the House floor as we speak, waiting one vote away from the governor, and we're hoping to be able to move that forward this coming session. So I'd be happy to entertain any questions that you all might have.
Thank you, Mark. Appreciate it. Have I overlooked someone that I've talked to? I talked to a lot of people, so I don't want to leave anybody out. Is John Scott, is he here? Do we have him? That's it. You know, what is amazing to me is that you got all these agencies in here. You got everybody from the Attorney General's office all the way down and up and all around. Agree on one thing. Something has got to be done. Some kind of legislation we've got a lobbyist here that even gave us the points to put in a bill, and I'm just telling you, to me, this ought to be an easy one to do, because we got everybody on board. Everybody wants to do something about it, and I think that's an amazing thing to have this many people in the room and agree that something has to be done. Mr. Chairman, I'm finished with it. We open it up for questions.
I've got a few questions. First off, I just wanted to thank the McKenzies for coming in. I'm a father of 3. I can't imagine sitting in your seat and telling that story. I don't think I could tell your story for you without tearing up. It takes guts to come in here, tell your story. It's the only way things change. We had mentioned Senate Bill 888 that I took over from the floor leader last year that addresses some of these issues, maybe a little bit. Pat and I have been on the same side, opposite sides. A.G. Carter and I have worked together on this. Mark, I mean, we're all in the same room trying to figure this out. I think Lyle could tell you that anytime that anytime you include practitioners, everything gets a little bit more complicated than it seems when we sit in here. How it affects their practice, who's in practice currently, who owns what, and I don't think, and I want you to know that none of that for the folks that are working with me to help fix this problem that are in this room care more about anything than patient lives and the lives of Oklahomans, and that's a fact. I don't know the new AG personally. I know the AG he replaced, his number one concern was the lives of Oklahomans, and I think AG Carter would agree with that. So I just wanted to thank you guys so much for coming. Know that we are working on it. Nothing happens fast in this building. I've heard that, Leader Eccles, I believe, was on this bill for 3+ years, and we made a lot of significant steps forward last year. And every time you do something, a different group steps up and says, well, this affects us this way. What would be the veterinarians? So then we're trying to exclude them. And there's only so much time that all these brilliant people will spend with me, and I can get them in a session, but we will work on it. I promise we'll try to get something done this year. I had, the crazy thing is, Lou pointed out, what was the name of that place? Oklahoma Treatment Services. So I Googled that. I have 4 pharmacies in Tulsa. I'm a pharmacist. I have been in pharmacy for 20+ years. I have a pharmacy 1.5 miles from their facility, 2.5 miles, and I've never even heard of it. I Googled it. It doesn't look like a place that I'd want to go, and it's also owned by, or actually the sign on the building says Right Way Medical, even though the name we got was Oklahoma Treatment Services. It says Right Way Medical on the building. So I'm sure they're probably doing things that, actually I can't say I'm sure. I think I have impunity in this room, AG, aren't I? So I'm not saying I'm sure they're doing anything, but it's not something that we don't need to look into, right? If you're causing problems one place, maybe we should check the other places you do business. Other questions I had. The PMP issue that the executive director that Marty brought up, Marty Hendricks, so that's automatically shot down by the federal government. There's nothing we can do there, period.
On the state level, again, you would have to take out the part that requires a patient consent, because that is a federal guideline that you're going to have to get that patient's consent before it could be entered into our prescription program. Yeah.
Okay.
It doesn't mean it couldn't happen, but again, somebody who's trying to avoid detection and feed an addiction, that's the last thing they're going to want to do.
Right. And Mark, since I got you, and I was on the NCSL, a fellowship committee with opioids that looked at this. I mean, it's hard to figure out what we do. The group in here before, from 1 to 2:30 is talking about suicide death and death from all the fentanyl analogs, and that yet we sit here today and we've done a great job at curbing prescription opioid use, but more people are dying because of, it's obvious, and it's in direct correlation to taking the prescriptions that they had away from them. So I think, again, a lot of the things that we'll try to do is not create, we want to help, and I think that's more mental health treatment than it is taking things away. Having the medical boards and the DO board, be harder on physicians. The pharmacy board, you're plenty hard on pharmacists. But one thing I'd love to see is for more doctors to lose their license for longer that have done this. Not have ophthalmologists running pain clinics. It's been an issue in Oklahoma for a long time. What I'll say to you today is I'll do everything we can to get something to make a step forward. I think we're always looking for perfection. It might not be perfect what comes out, but doesn't mean that we can't take baby steps. That's what happens in this building all the time, and that I know that the folks that showed up today are all working hard, and all worked really hard on this bill. It was a lot of late nights. It was a lot of conversations with everyone, and you wouldn't even think with a bill about pain management we'd end up with making the veterinarians mad, right? And everybody else. Anytime you change anything in medicine, every different group, from the mid-levels, the PAs, the MPs, the nurses, the doctors, the DOs. It's tough to get everybody on the same page, and they all have extremely loud voices in the building. But I can promise you that you have a good team that your story is, it's a terrible tragedy. It needs to be told in this building a couple more times between February and June, if you guys can do that. We need to have you sitting in front of the Senate. Need to have you maybe come to one of our caucus meetings and tell your story, because we do need to figure out some change, but there's a lot of listening to all those other groups, and there's so many of them that come out against changing something that seems small, but when it affects all their business, it makes it tough. I'll work for you on this. It's why I took the bill over, and I promise you the others in here are also working hard and trying to make just concessions with all the different groups, and we'll continue to do that. So I thank everybody for coming. Yeah, go ahead. Absolutely. State your name again, just so everybody knows who it is.
Sorry, Mark McKenzie from Pecola, Oklahoma. About the veterinarians, I find it strange. My wife and I, we have a little French bulldog that's paralyzed, or just became paralyzed about 2 months ago. And our veteran, bless his soul, he's an OSU graduate, and I don't hold that against him too much, but he said methadone would be one of the best treatments for our little French bulldog, but he can't even get it to prescribe it to us because they're afraid of that the veterinarians might get the methadone might get in the wrong people's hands. And our little dog can't even get the treatment it needs to get well. Our little French bulldog, Indy. But and whatever we need to do, what's so hard? The last thing we got to buy for our daughter was a headstone. So whatever we have to do to help other people, and just to know that we're willing to do whatever we have to do to make things right and not let these clinics just run and give out methadone or sell it for cash to whoever. And we're willing to do whatever is asked of us to see that some kind of regulations are brought upon these clinics. Thank you.
Well, thank you. We will be calling on you because it gets contentious, and it's a hard topic because there's so many people involved. So we will be calling on you this session to help us get this done.
Thank you.
All right, thank you. Rick, do you have anything else?
Mr. Chairman, thank you for your words that you said. Mark, everybody that came, appreciate you coming and telling us what we need to do. Mr. Chairman is right. Things will work slow up here, but I can assure you that we're going to do everything we can. This is Chairman's bill, and I know he'll work. It's very well thought of up here, and I think we're going to get something done. And I just really appreciate everybody that came. And so with it, if there's no other questions, if that's it, Mr. Chairman, I'm done.
All right, we're adjourned. Thank you, everyone.